I just want to say something. Welcome to the November Board of Lancashire and South Cumbria ICB. If I could start, as always, by thanking members of the public who are observing this board meeting, either in person or through the live stream. I'd also like to welcome new colleagues to the ICB board. Aaron Cubbings to his first ICB board meeting as Chief Executive Officer. Jane Scattergood as Interim Chief Nurse. And Silas Nichols as partner member for the acute sector. I'd also like to welcome Paul Hegarty, ICB Associate Director for Population Health and Place Delivery for Blackburn with Darwen, who's going to present the item on community experience to the board today. I've received apologies from non-executive member Debbie Corrican. I do have some comments that I will feed in at appropriate points from Debbie. Partner member Denise Park, Associate Non-Executive Steve Spill, and regular participant Health Watch David Blacklog. The meeting is, however, quorate. As always, I would wish to maximise time for discussion, so if I could plead with executives to keep their introductions very short. We have all read the papers and have digested them, so that we have a really good period for discussion. So I haven't had any declarations of conflicts of interest for today's meeting specifically. Are there any that anybody would wish to raise at this point? No. Obviously, if they arise during the meeting, please do raise them. So moving on to the agenda then, we've got first of all minutes for approval. The ICB board meeting held in on September the 25th. Are we content with that as an accurate record? Yep, excellent. Matters arising and action log. I don't think there were any. I just jot down some, but I think they were all covered either in the agenda or in the in other things. Does anybody notice any matters arising that we hadn't picked up we should have done? No, great. And the action log, I think, is there are no outstanding actions. Then the second set of minutes we have is the ICB Annual General Meeting minutes from the 25th of September. Are we happy with those as an accurate record? Excellent, thank you very much. So we move now to the community experience story, and I'm very pleased to welcome Paul. This is about the work that we are doing around neighbourhoods. Specifically a project with the VCFSE in Blackburn with Darwen. Over to you, Paul.
Thank you, Chair. Yeah, so just to introduce, this is a project we've been doing for a couple of winters now in Blackburn with Darwen, specifically in Blackburn Central Ward, and it's born from the work we did around priority wards a number of years ago. And it's overseen in Blackburn with Darwen by Blackburn with Darwen Health Equity Group, which is a collection of partners, voluntary sector, local authority, various departments within local authority, ICB, the trust, who come together around common issues. So it's not a formal group, but it's a group that's really passionate about identifying certain areas that we want to focus on and then addressing them. And Blackburn Central project is right in there as one of the key areas around health equity. So in Blackburn with Darwen, male life expectancy is 67. So that's putting it into context that we're not talking about just inequalities, we're talking about significant inequalities against the English average, but also then the local average. All lower super output areas, which are the geographies that we work around in that area, are in indices of multiple deprivation 1. So they're all the most vulnerable, most challenged communities. Very high percentage of together housing stock in that area, who provide our social housing, and a lot of old terrace stock, so really deconditioned stock, and also some really steep hills. So it's quite a hilly area actually, surprisingly, around there. So it's a challenge to the population. It's also a very transient area, so we have a lot of people who come in and come out of the area regularly. So trying to get a handle on that and manage some of those conditions and make sure they're in the right place at the right time is quite difficult, really. And it also includes large HMOs, which are houses of multiple occupation. Now in Blackburn, we've got a couple that have got 60 plus rooms available. They're managed by the Salvation Army, former hostels. So they're really big groups of populations who congregate there, many who've got significant challenges and have been through a number of different services. And it's also banging the town, just covers the town centre, which includes Barbara Castle Way. So we've got some really good infrastructure there. Maybe it's about how we might repurpose and reuse that. And we've also got a number of GP surgeries in that area. So the project we're going to play a video on in a moment is around some of the work we've been doing with a partnership model. And it's involved some of that, the 2% top slice that was applied to the non-recurrent urgent care funding, and that's been administered through colleagues at Spring North. And they've given us some really solid foundations with which to monitor the project and work through the project. But in 2024, the partnership included Red Rose Recovery, Project 180, St Luke's Church, and also Thomas, which is an organisation that works with those on the margins of society. That's what that stands for, Thomas. And 2024 was less data focused. It was about getting out and engaging people. And in 2025, we've got a slightly reduced financial envelope this year. So the partnership is just Project 180 and St Luke's. And we've really focused on data this time. We've looked at different sources of data and tried to focus on specific pockets of our communities. And that's taken us into 3 particular postcode areas. And that's not just single postcode 6 digits. That's 10 postcodes in an area. And we've worked in there to try and understand what is it in that area. Because in those areas, they include industry and business, and yet still there's over 2,000 attendances in that small group of a population. So the ward's 10,000 in these areas, there's probably only maybe 1,000, 1,500 people, but it's 2,000 attendances in that area. And we can see from the data there's lots and lots of people in there. And then also what we're doing is working with primary care data. So these people aren't just attending A&E, they're attending primary care regularly, contacting regularly, they're going through 111 services. They're also going to the food bank very regularly, so we can understand the food bank contact and the other triangulation of all our data. And Andy, you've been to the food bank in Blackburn, you've seen what a wonderful job it does and the data it includes and it holds there. So that's not just about providing food, that's about providing advice, support, guidance, etc., etc. So this is all in the context of neighbourhood. So we're not doing this as a separate project. This is about how integrated neighbourhood teams work, how PCNs work, how we work with social prescribers, how we work with our children's hubs, family hubs in Blackburn with Darwen. And we've been fortunate enough to work with the colleagues in this video who Mark's going to play that video now.
So my name's Fionn. We are in the 180 project, Help Hub we call it, and what we do here is we talk, we train and we transform together. So we use sport as our methodology to get people mentally and emotionally, physically and socially well. So we got involved with the winter capacity programme because we were getting frustrated with people not getting the right support at the right time. So we saw our place here as, you know, we use physical activity, we help people mentally and emotionally, we help people socially, and we know that that stuff can underpin fundamentals, I suppose, that would stop people from reaching crisis.
So I'm Emma Mayo, I'm the Social Action Lead for St Luke's Church in Blackburn, up on Bank Top, on the edge of the Central Ward. We had a lot of time with the healthcare teams, just about giving knowledge to not just one person in that family, the whole family, and bringing them together. There was someone who had a child with asthma, and their usual reaction was, if the child was going into a bit of a crisis with their asthma, was to go immediately to A&E, because they were in a panic and they were just being a mum, and that's what was best. On this occasion, the child had started with what they could see was going to be an asthma attack. They rang 111 instead of going to A&E. 111 then got a GP immediately to phone them back, and within an hour the child had a new inhaler, a new regime. Within 2 hours they were stabilised at home. But also that parent knows that if it is crisis, to go to the hospital. So it worked really well that she picked up, right, actually I can ring 111. We had another family, a Polish family who we worked with, and we did a lot of kind of trying to explain to them, you don't need to go to A&E. They were attending A&E with minor things, you know, an ingoing toenail, and we're up there, you know, we're messaging staff, been up there 5 or 6 hours with something that could have probably been addressed with a GP. Trying just to embed that change that we haven't got to go to A&E.
So yeah, so that's last year's video. So we're currently midway through our 2025 project. Fionn and Emma are absolute pillars to this work. They are the people who are doing this work in the community every single day. And what we've been doing is going to people. So last year we kind of tried to go to everyone, but this time we're trying to focus and go into communities. And we're trying to develop neighbourhood networks so people are connecting with each other. So when we engage with someone, we connect people and we connect people together in order for them to start to work by. And that's led by citizens who live in those communities. So we're trying to build a sustainable way of working and not just one-off engagement. And that's community connecting. 101 is the mantra for that. And we've called it, some people have called it in the project, it's kind of granular social prescribing. It's working with people in a really small way to change little bits, whereas social prescribing might try to manage finance or mental health. This might just be small pockets of individual issues within there. Two of the big factors we found are isolation. This will have come through when other people have been to this board and talked about patient stories. Isolation is a huge factor in this. The people who are often engaging prefer to reject intervention and actually prefer episodic care because it means they can choose when and how they want to receive, but that's not actually benefiting them in the longer term to have coordinated care that's centred around them and giving them the support through general practice, etc. And the other issue that is apparent massively in this population group is health anxiety. It's been a significant part of this around presentation, COPD particularly, because it's quite a visible and an emotional reaction, but also chest pain and others, and that's matched by the statistics for people who go in with very, very little time spent in A&E departments, information, advice and guidance, and we're working with our colleagues in ELHT at the front door around some of that work as well. So this project will finish in March 2026, and that'll be the second round. We'll then have a slight fallow period until potentially next winter, and that's one of the challenges for this. It's about we will keep the ripple effect, but we'll lose some of the momentum in between. And it's how do we start to address and turn some of that work around. Now, we are going to have some targeted demand management funding through the population health team, and that's a huge benefit to us. And we're going to look to work around this with our local GP federation to build some of that and think about that. I suppose for me, this could have been Claremont or Bloomfield or other examples of work that we've done in those areas. And it's not, the themes aren't unique, but the solutions are. And the support is unique to Blackburn and the people of Blackburn with Darwin. So thanks very much for your time. And that's the story. And I'd just like to say that I would have loved to have the colleagues who are doing the work sat next to us. Fionn's just had a baby and Emma can't make it and others. So there's all sorts of reasons they're not here today. But they said I could represent the project here today. So thank you.
Thank you very much indeed, Paul. And it's particularly, we should always also remember that this is one of the two areas in which we have a neighbourhood hub as well, which is a sort of wider version of this. So, board members, any questions or thoughts? Jim.
It's sort of an observation more than a thought, I think. Thank you. It sounds like it's a really great project and it's being very successful. It's in Neil's introductory paper, it talks about reaching people who are previously invisible to the system. And I think that's almost like the big advantage of this, and the impact it has on, in effect, dealing with issues before they arise is so important, and almost avoiding issues further down the line, basically. So we can't underestimate the impact these schemes have, in effect, on almost preventing issues arriving at the NHS front door. So it's a great scheme for what it's doing. You mentioned isolation as an example, and That's something we don't really take into account. They're like social factors rather than health factors, but they have a big impact upon health. So, yeah, it was really helpful, and I'm very impressed by it.
Great, thank you. Yes, Tracy.
Thank you. I just wanted to put a bit more context to how all this work kind of happened, in terms of it started about 3 years ago with conversations between the VCFSE Alliance and colleagues around this table, and other colleagues across the ICB and the Alliance. And the reason why we got to the point where 2% of the UEC budget was used in a different way, because actually what would have happened with this money is it probably would have gone into acute trust to pay for more beds. But the ICB took a bit of a leap of faith and said, we recognise that we need to start doing something different. So through some task and finish groups that involved a lot of people across the VCFSE, we worked up some proposals. And to kind of cut a long story short, because there was a lot of work that went into this, and Craig is nodding because Craig knows all about it as well, we got to the point where the Alliance was given a lot of flexibility, and this is in the report later as well, around that kind of model of tight, loose, tight, where there's really tight parameters around what the money's for, freeing up the ability for decisions to be made across the VCFSE Alliance, and then really tight metrics about how do we measure what we've achieved. And Blackburn is one of the areas, Blackpool is another one of the areas where this money went last year. It's been expanded to cover Lancaster and Morecambe in this current winter period. And these services across the VCFSE, we're doing this work on the ground, and what we've been able to do, which is the kind of holy grail within this, is integrate it within the NHS. And that's the big difference that we're making. We're pointing VCFSE services in the right direction for our population, and that's where the magic's happening, and that's why this is so significant, and why I wanted to kind of put it into that context. Of course, I would say this, 2% is a drop in the ocean. Just think what we could do if we had more funding, more investment. And I know, Paul, you're looking at that through population health. Yeah. I think we need to look at that as an ICB, as a way forward. This is shifting the dial on some of the things that around health inequalities, around the 10-year plan, that we're absolutely being given a call to action to do. We've started really small with this. The potential of this is huge. I'll leave it there because I'm not going to kind of say any more, because I think we're going to talk a bit more about this later on in the agenda. But I just want to say a big thank you to Paul, because you have articulated so many of those changes that are happening in a small way in those communities that I know my colleagues across the VCFSE are doing every single day. But the reason that they're making a difference is because they're keeping people safe and well at home. And that's the big key factor in this. So thank you for coming today.
Just to add, we could have brought the Age UK example from Darwin. Absolutely. Here. So there's all sorts of those.
We could have brought the Blackpool examples. Exactly. We could have brought any examples, but I'm really glad you brought, because those complex lives examples are so crucial. Yeah. Because often, as you've said, the cohort of people that people have worked with in Blackburn are often the people who are left behind, who slip through the cracks, who have very difficult lives, who overuse our health service because often there aren't other services that are meeting their needs.
No, thank you. And I was privileged enough to visit some of these places when I came, and it is really inspirational. The challenge we've always got is how do we build on that? And I think that's one of the things that we're looking at in terms of our strategic commissioning. The other thing that came through to me, picking up on your point, Tracy, is the use of Spring North, because my previous experience is that it's very difficult for the NHS and a very small VCFSE organisation to manage that interface, because our needs, we operate in very different ways. So that having that intermediary organisation is quite important, isn't it? Yeah.
Spring North were brilliant in the work that they did, absolutely.
Yeah, Kath.
Thanks, Chair. Yeah, I think it's a fantastic piece of work, and I've been busily writing down. So I want to make sure that sort of South Cumbria is in that consideration as well. Thinking particularly, sort of Barrow area and South Lakes. I guess the other thing for me is, and it's that interesting point, isn't it, on shifting the dial on health and equalities is so important. But the potential impact for this, yes, it will help to manage demand for health services, but it will also have significant impact in terms of social care provision as well. And I think we need to be really thoughtful of, as we're making decisions that will alleviate some of those pressures around acute care, that actually the resources are transferring into the community to enable VCFSE and social care, etc., to be able to then meet those needs, particularly in line with 10-year plan and the plan for more people to be looked after at home. So yeah, that's just mine to keep us all in the mix, but interested in a conversation, definitely.
Sorry, Jane.
Thank you. It's a news item, if I may, Chair, and it's only just come in since the papers were written. The ICB Women's Health Team bid for money to build on the work in Blackburn with Darwen, this neighbourhood multifaceted support. And we're one of only 2 ICBs to receive funding for the CLEAR project, which is heavy menstrual bleeding and urogynae, and it'll operate in that neighbourhood footprint, and it's brought in some extra resource and opportunity for Be With Thee, but then learning across all our neighbourhoods.
Excellent. That's great. Very good news. Okay, Aaron.
Thank you, Chair. Paul, thank you for that, and Tracy, thank you for the update. So this speaks to a lot of what this organisation is now starting to develop. So you could, on the one hand, say that's a really good example of trust and confidence in a partner and giving some resource, but 3 years and 2%, and you know, it doesn't sound pacey to me. And actually, when we ask for evidence and does this work, invariably when we test in places like Blackburn with Darwen or Morecambe Bay in the Pathfinders, the evidence is really clear that this kind of partnership and this kind of investment really does deliver real benefits to community. So there's a couple of things that we've been talking about just today as a board around how does the policy now that's developing and the strategic commissioning framework help support more of that kind of working. So we're going to talk about revisiting the partnership for the VCFSE Alliance today. But having longer term commitments financially that give a bit of reassurance to smaller partners that they can invest and kind of take some of these programs forward. And some of the work that we're doing now around how do you measure success? So I think we'd all recognise that a lot of it is in quite a lot of acute community access and waiting time type areas which eat a lot of resource. We were talking today about what would a dashboard look like where you were measuring kind of lived experience, access in different parts of the system, outcomes for those areas of the population that sit across all our public services, and what does that look like? So I'm really keen to explore with the VCFSE Alliance, what does that medium term kind of relationship look like? And with broader partners, to your point, Kath, I think sometimes we pitch against each other a little bit based on finances and risks. We forget that the communities that we serve are the communities that we all serve. And there's a benefit in coming together in a different way to make sure that communities are getting what they need and want. And I do think the policy shift helps us in that regard. So I'm looking forward to working with colleagues over this next period to see if we can do a bit more than we're doing currently.
Great. Excellent. Good start. Paul, you're more than welcome to stay. I suspect you've...
Not many people take you up on that.
No one ever takes me up on that. Okay, so we're now at the Chair's report, which I think you can take as read. Very happy to take any comments. Just a couple of words. So, I mean, I've said, firstly, I am delighted, really delighted to welcome Aaron as CEO. He brings huge experience, and I think as you've just articulated, he has a real vision for this area and for what we can do as an ICB in that. So I'm really looking forward to working with Aaron on that agenda. And I also did want to just mention Jim Burrell, who leaves us at the end of December. So this is his last public board meeting. And I'd like to formally thank Jim for his dedication and commitment to this ICB since it started. And I have really valued his input and counsel since I've been chair. So thank you for that, Jim. There are just 3 areas I wanted to touch on in relation to today's board. Board members will be aware that since we last met, there has been a national redundancy scheme published. Aaron's going to provide a bit more information on this, and it's clearly a fast-moving situation. but it is of course very welcome news in terms of allowing us to provide our staff with greater clarity and control over their own future. The second thing I wanted to draw board members' attention to was that we had a meeting in early November with the regional office to discuss our programme as part of a wider regulatory meeting against the undertakings that we made at the start of this year. It was a very positive meeting, and again, more detail will be provided, where we were able to demonstrate significant progress in terms of strengthened governance, leadership and financial grip. The issue for us, obviously, in terms of exiting oversight is the delivery of the financial the financial target at the end of this year, and that is going to be very tight. We'll come to that later in the agenda, but we do have robust plans, but it's a very positive. It's positive that we made that level of progress so far. And thirdly, we are currently working on the development of our medium-term plan to respond to the requirements set out in the recently published Strategic Commissioning Framework. The approach that is set out will force us, as Aaron has started to articulate, and as will become clear in the paper later, to think about the way we operate in a very different way. This, of course, links back to how we structure ourselves to ensure that different functions within the ICB are there and are functioning in the correct way. There's an update on our progress on the medium-term plan later, but this is clearly an area that we will come back to. It's also clear that our approach and impact on transforming services in this very new and exciting way will develop and improve as we deliver the structures necessary to do that. So that's, I think, all from me. Very happy to take any questions on my report. Otherwise, I think we'll move on to Aaron.
Thank you, Chair. So day 19, so I do feel a little bit fraudulent kind of presenting some of the things in this paper because a lot of the actions in here obviously were taken forward before my arrival, but I'll just say a few words, Chair, and pull out a couple of key themes in the document. So I wanted to start off with a massive thank you. Thank you to Sam Prophet, my predecessor, in the work that she did with me in transition to make sure I arrived as well prepped as I could, but also a huge thank you to board colleagues and wider colleagues in the organisation who have been incredibly gracious and incredibly kind in giving me some of their feedback, in welcoming me to the organisation and starting to talk to me about their vision of the future and how it feels to work in our organisation. So I'm really grateful for colleagues kind of receiving me in that way. I wanted to mention something that the Chair has just referenced around the restructure of the organisation, in particular the voluntary redundancy scheme that's just been launched. I need to start off by thanking all of our colleagues in the ICB. It's been clear to me in my first 3 weeks that the focus on improvement, the thinking through what it means to take forward more programmes like we've just heard Paul and Tracy articulate, and also thinking through their own futures at a time of real uncertainty. That's not been lost on me in these first 3 weeks, and colleagues are being kind and supportive of each other, recognising that uncertainty. What we've been waiting for through kind of the early autumn is some permissions from the NHS national team and the Treasury as to how and when can we take forward the proposals we need to make the changes that ICBs have been asked to make. And I know we've talked here before as a board on things like the model blueprint and what ICBs are going to be asked to do in the future. We received that notification 2 weeks ago and we launched our voluntary redundancy programme yesterday. So colleagues now are considering what that means, making the appropriate applications, and we're supporting colleagues through that over this next period. So I just need to recognise with the board that's quite an uncertain period. There's quite a lot of instability, but I'm fabulously impressed with the work of the People Services team with Debbie and also Neil and the engagement team and how we're supporting colleagues through this and having the conversations with colleagues. And I've been able to speak to groups of upwards of 500, 600, 700 at a time over the last few weeks to get that moving. So I just needed to recognise that here, Chair, because it's quite a fast-moving piece of work. More broadly, I've spent quite a bit of time visiting a number of teams, even in the first couple of weeks, whether that's our Women's Health Network or the All Age Continuing Care team, and certainly on team briefs, hearing clearly from our place leaders and neighbourhood leaders about the work that they're doing. but a lot of time has also been spent with the executive team and the leadership team in a couple of key areas. So we've received the medium-term planning guidance and the strategic commissioning framework. We're just considering our response to those, and you'll see a bit of that on the board agenda later. But I've changed a little bit of how the exec team and the leadership team are working, just to provide us a bit more headroom on what does it mean to be a strategic commissioner? How do we really start to manage a market? How do we really focus on population health improvement? Because we've got lots of opportunities in front of us now. And we've had a couple of weeks of that, and I'm looking forward to a session with the board later in December to walk through some of our early thinking. We've also, as an executive team, had a number of issues to consider, which you'll see iterated in the report, which I won't pull out in detail, but a clear focus on this year's financial recovery, a clear focus on access, in particular elective recovery and waiting times, and we're working with our partners around that, and preparing the organisation for change and planning for next year. And they're largely the three areas of priority that I'm working with the executive team on. There is one element, though, that I would want to pull out in terms of an executive committee decision, and that's the conversation that happened back in September, I believe, with the board around weight management drugs, or GLP-1, you might hear them referred to. There was a conversation about how do we give guidance and direction to prescribers of those drugs as to what we want to commission this year, what criteria we would want to use for that, and a recognition that actually some of the funding and the budget available didn't allow us to expand the access to that kind of drug as broadly as some of the guidance might indicate currently. So we've been in conversation, particularly with Andy and the regional and national team, just to come up with some criteria that we can start to give some guidance for prescribers for this. And what we've done is we've come up with a methodology based around BMI in particular that starts to stratify the highest risk areas of the population that can gain access to this drug quickly, and that's a decision the EXCO supported following a mandate from the board. That doesn't mean that that's the scope of the prescribing population going forward permanently, but it does mean we've got clarity for the rest of this year over the next 3 to 4 months. There will be a paper that comes back, Chair, in January, starting to articulate with the board what the broader prescribing strategy is for GLP-1 medication over next year, and to recognise that the impact that that has on obesity and the associated conditions around obesity is significant. So it will be something we'll want to deploy well in our next period. So they were the only 2 or 3 areas that I wanted to highlight, Chair, but I'm happy to take any questions on the paper.
Thank you very much, Aaron. Any questions for Aaron? No. Okay, thank you. Very comprehensive. Right, so we now move to Jane and the alert report from the People Committee.
Thank you, Chair. This was the People and Culture Committee which met on the 15th of October, and the first item that I'd like to alert the board to is around a deep dive that we took into health and well-being and sickness absence within the ICB and across the wider system. We have a deteriorating picture around health and well-being, and also increasing levels of sickness absence. And we looked at this in some depth in the committee. I think some of the main outcomes were the fact that we feel satisfied that there are plenty of offers in place to support health and well-being, but we're not sure whether they're all effective. So one of the follow-up actions that we're going to look into is to try and review and evaluate those different interventions to see which ones work and which ones are not making much difference. And another area for further work is around looking at hotspot areas, because it's not the same in every team and every area. So we want to drill down a little bit more into divisions and some of those areas to try and understand better the need in particular areas, and to tailor the health and wellbeing offer based on, make it more bespoke. The other side of this is a shift needed from managing sickness absence to managing attendance, looking at this from the other end and looking at the drivers for sickness absence and changing policies to encourage returns to work and conversations to try and maintain people in work, rather than try to get people back into work once they're absent, which is much harder. The other aspect that we looked at in line with the Equality Action Plan was also to have a look at people with protected characteristics and see if there are any trends there. So we need to do, so there's some follow-up work needed. I will just mention that after this meeting, this item was picked up by 2 other committees because sickness absence is having an impact in performance, in our performance more widely. So the Finance and Contract Committee wanted us to look at the impact that this is having on productivity across the system. So that's something we're going to return to in January. And the Quality and Outcomes Committee raised the fact that clearly it's affecting our ability to deliver services in key areas, and also a kind of wider look at business continuity related to absence, not just sickness absence, but how we're managing vacancies and priorities. So there's some follow-up work on this one that we need to bring back to the committee in January. But I think it is a significant problem that we need to prioritise and address. The other alert for the board, really, first of all, we are asking the board to approve via this report the combined pay gap report that we've produced. We're legally mandated to provide a report on gender pay, but we've chosen voluntarily to also look at ethnicity and disability and combine them into a pay gap report, and also into an equalities action plan that brings all these themes together. I did want to highlight the fact that we need to be diligent, really, in trying to increase the diversity of our organisation. We're not yet sufficiently diverse. And the other thing to call out, because we've seen it before in staff surveys and so on, is that there are still some issues related to bullying and discrimination in our workforce, and we need to call that out and be increasingly vigilant through the delivery of our Equality Action Plan in making sure that those behaviours are seen to be totally unacceptable and not part of our organisational values. So I did want to kind of still alert the board to the fact that we need to carry on doing work there. The only I'm trying to think, the only other aspect that I wanted to highlight, I think, was we did, in terms of just advising the board, we did have an issue. We did talk about how difficult it is in the current climate around students obtaining jobs and factors around recruitment more generally, whether that's from local communities and internationally. And we're going to ask the NHS England representative to come back and give us more information around all of those themes, because in terms of securing future workforce, we need to make sure that we have a pipeline coming through despite all the change and transition and financial constraints. And as I say, I mentioned the Equalities Action Plan, just to assure the committee that we do have that in place. So happy to take any questions, Emma.
Thank you, Jane. Any questions? Yes. Thank you, Anne.
Thank you, Chair. Only 2 quick points, Jane. So I'm aware that a good quality occupational health service can help with that, keeping people well in work for as long as we can. There is a piece of work, I believe, across one LSC, Debbie, looking at occupational health provision. So it may be worth just exploring whether there's something in that shared occupational health delivery model we want to explore in this next phase. If we can pick that up, I think that'd be helpful. The second is, it's just for some reassurance for board. Having feedback from colleagues, which I've heard in my first few weeks around equality and diversity, the importance of having diverse workforce and bullying and harassment, is we need an escalated infrastructure now through the organisational change process. We're about to completely change the organisation. So I know Debbie is on this with the team, but having real clear quality impact assessments, diversity assessments, as we're making those recommendations for voluntary redundancy, etc., just some reassurance from the board. Yeah.
Yes, the transition committee's been quite keen on that. I just wanted to pick up on the. Was the committee assured that so we've covered this issue of the wider question of bullying and harassment and the sense of were you assured that the actions are in place, that it is a question of letting them in bed, or is there more work to do to develop further actions, do you think?
So, I mean, I'll also ask Debbie to respond to this, I think. There's more work to do, and that's captured in the Equalities Action Plan. So we're not there yet, but we have a plan. So it depends on delivery of that plan would be my sense, but there is work to do.
Fine. Debbie?
Yeah, I think many of the areas that we've had to alert as part of this committee do relate to line management capabilities, and I think that's a key focus for us around supporting our line managers to manage well, particularly during this time of transition and organisational change, whilst they're managing their own, their own emotions and experiences of it. So that's one thing. That's one area that we're working on. The other area, in terms of particularly around the sickness absence, we do our service is provided by the ELHT Occupational Health Service. But one thing that, and actually the trade unions raise this as well, again supporting our line managers to manage absence, asking the right questions that will encourage a return to work. They may not be fit to return to their substantive role, but at least a gradual return. So we're working really, really closely with our trade unions around that, because actually they raised it as a particular area that they want to support us with.
Yeah, because that improves health as well, doesn't it? Yeah. Okay, any other points for Jane? Yes, Andy.
Thanks, Chair. I think my point would be this, which is I think both the committee and us as a board need to be clear about what we mean by zero tolerance. So we talk very openly as an organisation that we want to have zero tolerance in terms of being anti-racist, in terms of any gender discrimination, any discrimination in terms of sexuality. And I think in terms of the People Committee, one of the things that would be good to monitor, I think, as part of this process is our own approach exactly to the people plan that you've talked about. I just want to kind of emphasise that point, that I think it's really important for me as the race equality champion in the organisation, that that policy is really being followed through. And so when we say we have zero tolerance around racism in the workplace, or we have zero tolerance around anything that it would be gender-based, for example, that our staff feel really safe, that the policy backs up with action as well as word. And I think it does, but I think it's really important that the committee is able to feel really assured on that, and that our staff also feel assured on that.
Yeah, very important point. Thank you, Andy. Okay, so I'm now going to move on for the Working with People and Communities Insights report from Neil.
Thanks, Chair. So the report again demonstrates that engagement, involvement and listening work that we've been done since the last period that we've been working on. I think in the introduction it's important to recognise that the insights that we capture feed into the work around commissioning intentions, and in the last month has also been feeding into some of the system quality group as well. So trying to make sure that different parts of the organisation hear some of those common bits of insights. Just a few quick points, if that's okay. Just a recognition to some of the communications teams across some of our trusts in the ICB who brought their skills together and listened to some of the feedback we had from winter campaigns last year and have done some really good work around a Good Health Starts campaign that we're really looking to promote across the system. It supports the UEC paper later as well. And also throughout delivering some of that as well, we're doing some of that outreach, so we hear some of those experiences on the ground, but working with our community partners, voluntary community faith sector, local authorities and schools as well in terms of how that's being distributed, but really want to recognise some of the work that's been done there. Also in section 4, I just wanted to highlight some of the work of our Children and Young People's team and the Children and Safeguarding Assurance Partnership that's across the local authorities. Developing the way that we engage people is something that is continuous, and they've looked at the Lundy model, worked in collaboration, and now we've rolled out some training that's taken place across the local authority and our teams as well. And it's really trying to make sure that the way we engage with young people really embeds voices, and there's some really good work that's going on there between some of those teams. So that will really inform some of the way we go out and engage with those people going forward. I also just wanted to raise in section 5, sometimes we talk about some of the change and engagement work that we do that leads to transformation over a long period of time. Some of it, particularly the work that the cancer team has been doing, we've been able to use really quickly. So through some of the outreach engagement work we've done with some of our voluntary sector partners, being able to capture people's experiences and then use those to help raise awareness is something we've been doing a lot over the last couple of months. And there's a couple of experiences in there from Kelly and Kirsty, who are local residents, also members of staff, but they were able to really amplify some of those points around raising awareness, which I think has been really quite valuable. We've had a lot of coverage off that, and hopefully that's had real impact on outcomes for people as well. And finally, there's just some examples in section 7 around where we've listened to some other engagement work that's happened, particularly around where there's been involvement in things like oral health needs assessments, and also want to pay a bit of recognition to some of one of our staff network groups as well, who've been bringing some of our staff together who have experiences of using services and working with some of our commissioners to hear some of those views, kind of experiences of LGBTQ plus community, and feeding that into some of our commissioning teams as well. And I think they've done some really good work to be able to use some of our staff networks in a really positive way. Happy to take any questions on the rest of the report, Chair.
Thank you. Thank you very much, Neil. Any questions for Neil? Yes, Tracy.
Thank you, Chair. It's just an observation, really. I just really welcome this report coming to board. Thank you, Neil. And again, just highlighting where we can work collaboratively with the VCFSE sector does make a huge difference. And as you said, it isn't always about it taking time to make a difference. Some of those things can happen quite quickly. So yeah, thank you.
Thank you. Thanks, Tracy. Chris.
Cheers, thank you, Chair. It was just really on using the staff networks. I think they are an untapped resource in organisations, and I say that for my own organisation as well. I think when you really harness the power of colleague networks in changing trust policy, in changing commissioning and influencing commissioning intentions, that's such a powerful tool, and that real, I just think it's brilliant. So thank you for highlighting it in the report.
Thank you. Debbie raised some questions on this, which won't surprise you, of course. And I think the key question she raises in this and in the question around the medium-term planning. So I'll ask it now, but we'll perhaps draw it out in the section on the medium-term plan, which is, this is fantastic, and you referenced at the start of how we're feeding into the commissioning intentions, which is great. But it would be good to start to understand how we're building that into our planning, and I suppose I'm looking here at Aaron, for the medium term strategy, for the clinical strategy, how we're going to build, how we're going to ensure that they are built on both data and insights. Now we won't necessarily get all of that out today, but I think if we can just raise that.
Yeah, can I come back on that? So actually tomorrow we've got a session with around about 90 people who are patient representative community groups from some of our trusts, from some of our volunteer group, from Health Watch volunteers as well, and that's absolutely working on the clinical strategy and involving from a really early stage in the way that we develop that. But it's also built on lots of experience and insights that we have from those people already. So Andy and Jane, I know, are really passionate about making sure that absolutely what we do is based on those experiences and looking at how do we really work with those people who are, in some instances, they work a lot with some of the community to understand what will the health service, how will it be different maybe in 5 or 10 years, and actually how can we get some early insights from them about what that means for experience, and how do we build it in. It's a broad range of lots of other engagement that's going on with other partners and other sectors like the voluntary sector as well, but tomorrow is an opportunity to really bring some people together to look at how do we really start with that, and it will also inform some of the work we're doing around the broader plan and the long-term planning stuff as well. So we're trying to start in the right way on that.
No, excellent. Thank you very much. Yes, Kath.
Thanks, Neil. Yeah, it's great that we're going to, bring in people's voices into that. I was just wondering, where is that taking place? So will there be voices from right across the whole of Lancashire and South Cumbria patch? Or is it something that's maybe sort of central Lancashire focused and therefore will attract people who are maybe more living in this area, which is a very different experience to people who are perhaps living more coastal or rural areas?
No, it's quite broad. So we have got a session that is here, but it's both virtual and in the room. So we have a number of people. Our volunteer group that we work with has got representation from all of our areas. You tend to find where we've done quite a bit of our transformation work over the last couple of months, which has been in some of our kind of more further out patches. We've actually been able to bring more connections into the organisation. So our kind of citizens panel of people who connect with us is a bit broader because of that, and actually has more from some of those other areas. So no, it is across the board. And also we've worked with our trusts to get some of their kind of PPI groups involved in this as well, but also with some of Health Watch and their volunteers as well, each of the Health Watches, not just Lancashire. So we should have a good broad mix of voices, but that is only the start of a conversation. It's quite a targeted start of a conversation. We will need to do much more kind of broader engagement with different community groups, different parts of our communities that may be more less well heard or marginalised. So it is the start of a piece of work.
Great. Yeah, Tracy?
Yeah, and also, Kath, tomorrow morning there is a VCFSE Alliance meeting dedicated to the clinical strategy development, so there'll be representatives from right across places. So South Cumbria will absolutely be represented in that. And that's before the pen has been put on the page for the clinical strategy. So it's actually from the very beginning of developing that, so that's good news as well.
That's really good. It's just excellent. Great. Thank you very much. Okay, I think we will move on now to the performance overview, starting with the Quality and Outcomes Committee Escalation and Assurance Report. Sheena.
Yeah, thank you. Just a few sort of opening remarks before I go into the AAA report. So we are working through transition in our Quality and Outcomes Committee, which is starting to really focus on that, how we use the information that we have to look at quality and outcomes, and I put the emphasis on outcomes because it isn't just the inputs to what we do to providing care or commissioning care for our population. It's the so what question. So what does that actually mean for people's the safe effectiveness and the experience of that, both in the short term but also increasingly thinking about what does that mean for our strategic commissioning. And we are now working with a new integrated performance report, and that's starting for us to think about even more deeply about those issues. And certainly I've been reflecting both in our work this morning but also this afternoon about how we start to have a golden thread for everything we do that really focuses on using our data and our intelligence to inform what we do and to ask those really important so what questions, so that when we move into being more of a strategic commissioner we can start to shape things for our population in some different ways. So just wanted to sort of share that, and there's still a lot more to be done in how we shape up that committee, but I think it's starting to help us to think about those really important things. And I'd like to particularly thank Asim and his team for the work that they've put into that integrated performance report and helping us to start to ask some of those really key questions. So moving then into the escalation report that we bring to the board, I'm going to focus on the alerts. There are obviously areas of assurance and advice in there, but in relation to the alerts, I'm not going to go through them all, but I just wanted to just pick a couple of them out, assuming that people have read the report. And the first of those is around the histopathology services at East Lancs Hospital Trust. And there has been, and we have reported this to the board before, some challenges in the workforce and capacity there, and some work on mitigating that and ongoing system response. I think, whilst things are moving forward, what I would just bring to the board's attention is that there still are ongoing issues there, and as a committee we are maintaining an oversight of that to make sure that those continue to be there. And I think, again, this is thinking about what are the longer term solutions, particularly thinking around how to does the providers work together to respond to what is a tricky issue in terms of capacity there. The next area I just wanted to bring to people's attention was around children and young people's services. And there is, as we know, and you've heard before from our committee's escalation reports, there is a lot of complexity and also quite a lot of challenges facing children and young people's services. And that's particularly in terms of waiting times, and I would cite the neurodevelopmental pathway in that, and also about safeguarding pressures. So I think it's really important as we move forward to think about how do we put some short-term solutions into that. But again, it really loops back to my opening remarks that this is thinking about very differently about our commissioning going forward, and actually think about strategic commissioning in relation to service redesigns. We have some sustainable solutions to things like neurodevelopmental pathways, and actually think about how do we think about prioritising our resources for the future, and really take a step back to think about not just what are our short-term mitigations, but how do we really get into longer-term sustainable solutions. The next area I just wanted to pull out was in relation to infection prevention control, and we had an annual report to the committee which showed some absolutely huge amount of really positive work going on in infection prevention control. But because we've got our urgent care report later on in the agenda, just really wanted to highlight the fact that unfortunately we have got quite a low flu uptake within both our workforce but also our population, which obviously isn't having a really helpful impact on reducing flu within our population, and that obviously then creates ongoing challenges which we see in terms of our urgent care response through primary care into secondary services as well. The next area I just wanted to mention was about learning disabilities in autism, and really to think about some specific challenges, which again just really plays back to what Aaron said earlier about the importance of integrating our clinical and social care teams and thinking about an integrated response to our populations, because it's the same population that is served by both NHS and social care services, and think about how we further develop neighbourhood working in that. And then then I just wanted to mention around our patient experience and complaints, and the importance about the opportunity to learn. And Jane mentioned earlier about some of the challenges we've got around workforce within the ICB teams at the moment, and that's one area of several areas where we do have a challenge around the capacity of the team at the moment to be able to do the work that we really want them to do, which is about effective response to people who raise concerns, how we learn from them, and the most important thing, of course, is about closing the loop about how we to make sure we've had an impact on putting those changes in from our learning. So that's all I really just wanted to mention. Thank you. Thanks, Emma.
Thank you very much, Sheena. Lots of quite important areas in there. Silas.
Thank you, Chair. Just in relation to the histopathology issue at East Lancashire Hospitals, Lancashire Teaching Hospitals have been providing some support to them recently in terms of some of their work coming over to us to help them out in the short term. I know East Lancashire also considering some short-term staffing increases that they need to put in, but more significantly in the context of the planned shared pathology service that we're setting up, histopathology is one of our kind of key areas that we want to concentrate on first thing. There's a number of areas which cover everything from staff sickness through to redesigning some of the process pathways, as well as some investment in further equipment that we're going to need to help out East Lancashire in that area. So it's firmly on our agenda.
Great, thank you. Jane.
Thank you, Chair. Just building on Sheena's comments on children's waiting times, it's the welcome subject of regional and national focus, and pleased to say that we involved in a regional session last week at Alderhay Children's Hospital, and have embarked upon significant rapid improvement cycles and focused the ICB's attention on the needs of children's community services. And something that I've kept on banging on about somewhat, but Asim will forgive me, to report children's weights as a percentage of their lives. I'll keep saying it.
Yes, thank you. Important point. Sakthi.
Thank you, Chair. Just to beat the same drum that Jane just did, in terms of the focus on the children and young people services, and particularly this strategic intent on speech and language and the critical importance of those services, we are part of a national mission which is to get the best start in life for every child, and that's measured through the good level of development of which the NHS commissioning aspect has got a critical link in this. So I'm really welcoming the emphasis on that, and hopefully that will be picked up as an area to motor on with more pace than we've had in the past. Thank you.
Jim?
Yeah, thanks. There are 7 alerts in this note, which is more than I've ever seen before on one of these reports. Is that just because of the changing nature of the committee, or is there some underlying issue? Is the system starting to, I won't say fall apart, but are we starting to see more problems emerging as a consequence of which more of these sort of issues are being presented to the Qualities Committee? And so is there something underlying this that we need to be reflecting on a broader basis?
I think that's a really interesting question. Thank you, Jim. What I would say is that a number of these alerts are areas that we have brought to the attention of the board before, and you know, in the way that Jane's just beautifully described the response about thinking, working on the children and young people's finding different solutions. So I wouldn't say it's an indication of additional things. It's more about how we, as a committee, that we are continuing to keep closing the loop. So what we don't do is to say, right, well, here's something that's happening, we're going to bring it to the board. We do keep closing the loop and going back round and testing out how are things doing. Children and Young People Services being the one that I've clearly mentioned. But it is, I think, you know, just from, you know, sort of an observation, I think clearly, you know, there is a lot of challenge in meeting the needs of people. And I think, you know, we also, you know, have, I think, you know, a real eye through the committee to make sure that we do have a good oversight about what's happening with quality and outcomes and further developing our work. So I think it's a bit of everything really is in the answer to your question. Thank you, Jim.
So, lots of hands suddenly. So, Kath and then Jane.
Thanks, Sheena. Sheena, I just wanted to pick up on the safeguarding the dashboard quota relating to the deprivation of liberty safeguards. And I think there's a big opportunity for us here because, as it says in the report, we've got ICB and local authorities across the patch experiencing challenges, haven't we, in terms of best interest assessors, Section 12 doctors, and signatories for this. So I think if we got our heads together and actually came up with a different solution rather than trying to approach it separately, and is there actually an opportunity to create a bank or something like that between us, then we might be able to make some headway. It's certainly something I've been talking about with other DAS colleagues, so I'd be keen to have a conversation and pick that up.
I think we would absolutely agree with you, and I think going forward, trying to find joint solutions is the right way forward. Jane, is there anything you want to add to that at all?
I absolutely welcome that and recognise that it's quite a niche skill set, isn't it? And if we can maximise by doing it together, something I intend to feed into operating model as a suggestion, but welcome working with the DASs on that, Kath. Thank you.
Okay. Jane.
Thank you, Chair. I'm just reflecting on outcomes for children and young people because in addition to this, the board has seen, you know, on several occasions that we need to really improve services in that area. And I'm also connecting it with the story at the beginning and the increased focus on neighbourhoods and remembering Sure Start centres. Now, Sure Start centres has a, you know, was one of the most successful government interventions for children, and there's a strong evidence base associated with that. I doubt whether the government will reintroduce them, I may be wrong, but there is some learning from those. I'm just wondering, we've been talking about the kind of neighbourhood focus and hubs and so on. Can we transfer some of the learning from Sure Start, not just thinking about those in relation to adults, but in terms of our children?
Yes, Jane.
May I respond to that? Jane, I absolutely agree with that. We do have family hubs, local authority family hubs that are growing and developing over the last couple of years, and that message was received very strongly in our Improvement Challenge workshop. There's a lot to be done in neighbourhoods around integration, so local authority commissioning of services for well children, 0 to 19 services, dovetailing with health commission services for children with developmental need. You're absolutely right, they were a brilliant model, and I think lots of people in the room recall their impact and have learned from their impact formally. There's a good suite of documents from Public Health England about the return on investment in Sure Start centres. We're feeding that into the commissioning intentions.
Excellent. So, so I was going to just pick up. So ELHT pathology and biochemistry was red rated last time we brought it to the board, and it's now come down again. So there is some movement in that, which shows the committee is working. That was the first point I was going to make. The second point is really the so what, which I think board members have really helpfully picked up. So there is no point in raising these things at board unless we have some resolution of them. And I think we've had a couple of, so the dolls, I will look forward to that coming through the committee, getting assurance on that. I think the children's hubs and something like that through the commissioning intentions, which I assume is where that would come next. And then the other one that I'd quite like to put as an action, forgive me, Aaron, but we need to work out the timing, is the complaints handling, which we've discussed in the past, but I do think we need a review of that, don't we? If we are to respond to the things that are, yeah, okay. So thank you, very helpful conversation. Good. Right, sorry, where's my paper? Integrated performance pack. So Asim.
Thank you, Chair. So I think already we've covered a number of areas that is included in the performance report. So I think I'll just try and triangulate some of them areas as we go through some of the pertinent points. But just to remind colleagues, the metrics contained in this performance report is discussed in many different forums, and we've already heard about the Quality and Outcomes Committee, there's a Children and Young People Board, there's a Planning Oversight Group. So these metrics are discussed and tracked in a lot of detail in different forums. But what this report does, it brings it together across the different domains, and it gives us a reflection of the progress we are making, the pressures that continue to build, and what we are doing in response. And across most parts of the NHS, nationally and locally, we are facing rising demand. And in Lancashire and South Cumbria, what this report points to, this demand is visible in planned care, waiting list, diagnostic capacity, cancer pathways, and what we've heard already around children's services. But it was also important to say there is real good progress in a number of areas, whether that be ambulance performance, maternity smoking rates, dental access, pharmacy first growth, and reduction in mental health out-of-area placements. This report gives the numbers, but I think the context is given by the rest of the papers that we do see in this agenda. And just to reflect on the pressures and the demand increases, and I've covered this before, so a few months ago I talked about GP appointments increasing by 5.4% compared to last year, and this year we see that's already increased by 1.4%, and that's a cumulative increase. Last year we saw an increase in our UECs by 5.4%, and again we've seen an increase by 2.79%. And these are thousands of patients that we are seeing extra in addition to what we've seen previously. And the story starts really from the pandemic in terms of cumulative growth. In terms of elective recovery, the national position is 7.39 million people are waiting for treatment. Over the last year, there's been a reduction nationally by 2.4%, but we are going against this trend, unfortunately, and we've seen 8,000 more people added to our waiting list. We are seeing an increasing number of referrals in our waiting list by 4.3%, and just to put this in context, that's 95 extra referrals per working day that we are seeing extra going on into our waiting list. But although it's a challenging area, there is really good progress being made. There's a focus on long-term waits, and there's a lot of work that's happened over the last few months where we are trying to reduce anyone waiting more than 65 weeks. And we are working towards really reducing that number, potentially eliminating 65 weeks before Christmas, and there's a lot of good progress being made there. So, Chair, you describe the problem, but in terms of what we're doing about it, there's a number of recovery transformation schemes in place. We've got the surgical capacity that's increased now in our 3 surgical hubs. There is a number of different pathways that we are scaling up, like the pathway through pain pathway. Yeah, I know that people might want to talk about that in more detail. And then specifics, looking at our pressured services like gynecology and increasing in our activity there. And alongside the things that we are already doing around advice and guidance, this gives us confidence that we will start reducing our waiting list, and our forecasting shows that will be the case. And it also show, our forecasting also show there will be an improvement in our 18-week standard and in our 52-week standard. So yes, challenges, but we can see real good progress and interventions taking place. Moving on to cancer, previously at the last board I covered early diagnosis and early diagnosis at the earliest stages, stage 1 and 2. And in Neil's report, we saw already today the work that's happening by sharing patient experience and patient stories, promoting early diagnosis. But the report focuses more around what happens when somebody gets referred or diagnosed with cancer. So our 3 standards are around diagnosis and treatment. And it's a mixed picture. And none of our standards are currently being met. And it's something we have to definitely look at. But again, there's a number of actions taking place, ongoing pathway redesign, including urology, skin and lung cancers, and investment has now been made to each trust to support improvements with their local pathways. I think it's really good to hear today that there's already been a lot of discussion on children and young people services. And I'll talk a bit more around that. But in terms of maternity, our smoking at the time of delivery, we've seen an improvement, and we've seen an improvement probably month on month around this, or year on year. But there's still variation. We still have Blackpool being the highest place in the country for smoking at the time of delivery across the country. Yeah? So there's real variation across the piece. We've already talked about children's services, and I think it's really important that we have parity and the right focus around these services. Because there isn't the same national oversight mechanism for community services and children's services. Many of these metrics don't feature in an NHS oversight framework. It does feature in our integrated performance report, and you saw Sheena's report today really describe that. And what I'm proposing to do is actually make this a more prominent feature in our integrated performance report by bringing together the different aspects of the report. So children's services feature in mental health, planned care, and community services, acute services. And it's sometimes difficult to understand the picture holistically for our children. So there's a piece of work we will do that brings together all of these services, and we will feature prominently around that in future. Just last few areas, mental health, really good progress. We've now got our out-of-area placement reduced to just 1. Talking therapies, reliable recovery, nearly on target, and our dementia diagnosis remains strong as well. But as we've heard already, the concerns remain around the long waiters in autism and ADHD assessment. Primary care and pharmacy first. So pharmacy first, at the last meeting, Debbie asked a question around coverage. What we can say, the coverage and variation, the coverage is good. We got 98% of sign-up from our pharmacies, but that doesn't necessarily tell us whether referrals are equally distributed, and there's a piece of work we are doing around that. Dental access is, again, good performance, both in adult and children access is above trajectory, and our urgent dental activity is holding strong as well. The last point, which Sheena did allude to, there's an increasing focus around health inequalities in our IPR, and we do see that the healthy life expectancy gap, we heard that already in the patient story, that still remains sort of very different across our different population. But it's encouraging to see in our children's services there is progress being made, again working with the voluntary sector in some of our children's services, in attendances into A&E. So there is positive impact in some of closing the gap around some of our deprivation. So just to conclude, we can see pressures in many of our services, and there is a balance of financial support and financial pressures, because financial support and pressures will shape the pace of improvement. Yeah, and we'll hear a bit more from Mark around some of our financial challenges. UEC I've not covered because Craig will cover that with the impact of our robust winter planning. But as already discussed, these are not short-term fixes, because what we see is percentage increases up and down month on month. This requires longer-term strategic planning and redesign, and we'll hear from Aaron later on around our response to the medium-term planning and strategic commissioning framework. And it also requires to work with voluntary sector, faith sector, and that has to be a central component of this. We've already heard from our citizen story, experience story, and we'll hear later around the impact of schemes that are having a positive impact around unplanned admissions, neurodevelopment pathways. So I think the longer term fix to this is our medium-term plan and our strategic commissioning response. I'll leave it there and I'll pose for any questions with support from exec colleagues in relation to their portfolios. Thank you.
Thank you very much, Asim. A very good overview. Thoughts, comments? Jim Sackthie. Yeah, Jim first.
Thanks. I always want to see more data, and Asim knows that, and so I'm a bit nerdish in this. But in respect to what you're given, thank you for the information provided. It is very helpful. Just on urgency and emergency care, and I'm conscious that we will be talking about this in a bit more detail in a few minutes, but there's reference to the 12-hour wait in A&E, and the figure of 9.58% is mentioned. It's actually 16.7% in the next report, so I think it's the difference between type 1 and total A&Es. But 16.7% of the people who are turning up into a hospital A&E waiting for more than 12 hours is not an acceptable situation. There's a report last year which linked the length of time you wait in A&E departments to deaths in A&E departments, and this figure is growing. So we've got a growing, it's a problem, and we've got a growing problem, and it just feels like we need to understand what's going on around this. And almost linked to it is reference to the virtual ward programme, which shows reduction in the usage. It's potentially such a great resource available, and we're not making use of it. And it just feels like we need to understand that a little bit better. Where are we not using this, and why are we not using it? And could something be done? Because it's potentially, it's a number of extra beds we could have available at our hands, in effect, if we could make use of them to 100% occupancy of those facilities. So, two issues really. You may want to pause them until the urgency and emergency care issue. I understand that, but they've come out of this integrated performance report.
Yeah, thank you. I think we'll take it now, actually, because it's a wider, the UEC paper is slightly wider. Can we answer that question as to why we're not using the virtual ward beds as much as we should?
If you just give me a second, I'm just going to...
Shall we come back to it then when we do that? Yeah, let's do that. So I think it's a really valid question. Thanks, Roy. Sackthie.
Thank you, Chair. Asim knows this. I'm an avid follower of all the board performance reports across our system, and I really commend the efforts of how the data is presented this time round. Particularly, I can see one of our trusts used to have that, and now it's featuring in this board's report, and I refer to page 92, which is the statistical process control charts. So really, really helpful to see visually and be assured or otherwise. A couple of points. One is there is a real risk if there is little connection to the strategic intent, then this becomes a report which describes perhaps hitting the target and missing the point of outcomes. So I think I wanted to really encourage us to think about how we monitor and report outcomes and how ICB and the NHS's contributions are progressing against those outcomes. Very happy to work with colleagues to craft that. The second point was, and we discussed it last time, and especially in the context of prevention, some of the things that are really, really critical as NHS contribution are about vaccination, immunization, screening programs, early diagnosis, hypertension. Those elements appear to have dropped out over the last 2 reports. I wonder what the thinking is, and again, would highly recommend the board considers bringing some of those prevention metrics back. If it's not here, at least somewhere else. Thank you.
I think I've seen the vaccination rates in another paper, haven't I? Yes, yes. I mean, I think I'm also, Anna, I love data and numbers. You can have too much. So there is an infinite. There is always going to, there's that balance as to how you, and it comes back to the priorities that we keep talking to. So I think as that there's a, that would be all up my, and I can see Asim wanted to come in on this as well, so I'll do that.
So I just wanted to come on the outcomes, because I think exactly that is a really, really good point. And I think by moving the integrated performance report into the Quality and Outcomes Committee is an integrated performance outcomes report. So what you see in the committee is not just the raw numbers, but it'll be the harm or the lack of harm caused by some of the adverse performance. So that could be cancer performance, it could be waiting well because of the long waits. So there is a really good triangulation within that committee, and maybe that's something more that we need to bring out. And I take your point around some of the prevention metrics. We'll try and feature that back in again, Sakti.
Silas, are you coming in on this as well?
Yeah, if I can come in on the virtual ward item. So I about 2 months ago, I spent some time out with our clinical teams doing on the virtual ward, doing some patient visits. And I think from that experience and then looking at some of the data, a couple of things really struck me quite heavily, actually. So I think that the first thing what we're not doing yet across the provider sector is really scaling up the virtual wards. They tend to be sort of seen as a sort of optional extra rather than a sort of core part of the service offer, if you like. And some of that's driven by some gaps in cover in terms of not all of those services being 24/7. Some of it is driven by needing to work with clinical teams in terms of educating them and some of their understandable concerns about making sure that those services are safe for patients. But the other thing where I think we're also perhaps missing a bit of a trick is thinking differently about the virtual wards. So they're not just a stepping patients down from hospital care, but actually use them as a stepping them up into a virtual ward, in particular around nursing homes and residential homes, to proactively monitor a patient to prevent them falling or prevent them deteriorating further. Far be it as a provider sort of, kind of straying too much in the territory or sort of kind of commissioning decisions and intent, but it does feel that that could be something that we could look at differently on that kind of scaling up it aspect in particular as a way of getting a better use out of them. The final thing, just to sort of, before I hand over to other colleagues, is in my previous role when I was in the GM system, we did some work with Lancaster University looking at sort of the health economic benefits of virtual wards. And what that showed very clearly is that they work best when they're done at scale. If you're doing them at subscale, they are an add-on and quite an expensive add-on. The only way you can really make them work effectively, both from a clinical perspective as well as a financial perspective, is getting large numbers of patients through them.
I'll leave it. Tracy.
Apologies. Yes, about virtual wards. In so much as that we've had a lot of conversations across the VCFSE about where patients need additional support, and it's on your point really, Silas, about not necessarily in nursing or care homes, but more in their own homes, where maybe people can't access virtual wards because they haven't got that wraparound support. Again, how we integrate across some of the services that are already being delivered. So I think across the VCFSE in a lot of communities, there are services that could support people accessing virtual wards, but they're just not being delivered in a coordinated way. So if there's something we can do around understanding the needs of those patients so that they can be discharged from hospital, access a virtual ward if there are things in the community that already exist, because I'm conscious that I don't want to talk about extra investment, but I'm pretty sure that there's things that we could just align again that would make a difference.
Yeah, it feels like an area that's worth exploring. I mean, there's also communication. My experience is that people don't necessarily, and the term is not helpful. People don't want to be in a virtual ward. They want to be in a real ward, or they want to be somewhere real. So there's explaining that actually, because when people understand what it actually means, which is a wraparound care at home, then it is absolutely right for a significant number of patients. Yeah. Okay. So the next person is Chris.
Thank you, Chair. So it was just to pull out on what Asim talked about with out-of-area placements, and it's something we've talked about as a board for quite a while. But this is a really good news story about how you work together as a system. So between the ICB with Craig and with local authorities and all of the local authorities, clinically ready for discharges within mental health wards have halved. So we're now in the 60s rather than plus 120. That's enabled us to have 0 inappropriate out-of-area placements. We set ourselves a trajectory of having private mental health beds of no more than 75 by the end of this year. We're at 67 today, so ahead of trajectory. And so whilst that's fantastic for those patients, we've also good on the balancing measures. So weights are coming down for inpatient beds. They're still not same-day admission, and we need to do more to get to that space. But when we've got it right for patients, we've also got it right on the finances, and Mark's going to talk about that later. We are spending as a system 800,000 less on private mental health inpatient beds than we were in April. And it's a real success story. So I think it's really hard to bring that out in a performance report, but patients are in the right place, getting the quality care where they need it, and we save financial, and it's all through relationships and working. It's very good.
Thank you. Thank you very much for bringing that out. I can see 2 hands. I've got Sheena first and then Craig.
You would expect me to say this given my background, but I really just want to say to Chris and to the team, and it's the wider system, so that's a really, really positive achievement, which I think significantly improves the outcomes for people. So thank you, Chris, and everybody involved in that, because that's a really, really good piece of work. Thank you.
Craig, I'm going to be, yeah, got you. Craig.
Yes, just on that point, I absolutely agree with Sheena. This is true collaboration, and it shows strategic. I think partnership working at its best. So I think Chris's team has worked extremely closely with my team, and it's not been without its challenges, and there's been blood, sweat and tears along the way, but I think we've started to see some of the fruits of our labour. I was just going to pick up the point on virtual wards. We've had a very detailed paper to Quality and Outcomes Committee. It's a really mixed picture. So, for example, ELHT are over nearly 80% across the board. BTH and Morecambe Bay, again, over 70% in the last few months. October, we saw nearly over 80% as an aggregate position. We're third best in the country for admissions in virtual wards. So whilst there is a mixture, we've then got part of our patch who's only on 13% for virtual wards, and that slightly skews then our aggregate position. So I don't want the board to think it's about an underutilisation. I think if you adjust for some of these variables, it does show a significant improved position over the last 2 years. It might be worth something that the board want to see on the back of the Quality and Outcomes Committee report, because I think there is some really great information here that does show, as Silas said, some real improvements, and it's about clinical engagement and as you said, about what the patient's view of this is. So I don't want to do virtual wards a disjustice in this meeting, because I think there's a lot of positives in it.
No, thank you. Thank you. That's good to get that in real time. Thank you, Craig. I now have Roy.
Thanks, Chair. First of all, just to agree with your and Jim's comment about data. Yeah, I'm a fan of data as well, but I remember when the performance report used to come to Finance Committee, and there was a surfeit of data, I would suggest, that came with that report. However, this report is much improved, and I think the narrative within the report is a better, less than giving us just all the figures and the data. But just one thing I'd like to pick up on, if you don't mind, it's under diagnostics. And the Community Diagnostics Centre's activity being under plan in August. Now, I accept that might be with regard to people being away or on holiday or whatever, but a number of tests there at 4.5 this VCFSE, I see. A number of tests there undertaken, nearly 20,000 against a plan of 31,000, which seems quite low to me. They're a really good resource in my view, community diagnostic centres, and it just seems a bit odd that Preston and Westmoreland saw the greatest variance in that. It's two areas that just seem a bit diverse to me, and I just wonder if that could be explained at all.
So it's definitely something, Roy, we are looking at, and we are looking at the initial planning assumptions in terms of when the plans were submitted around the usage of community diagnostic capacity. We have bought this here previously, but I think it probably warrants another look at the figures. So if I may, if I can bring that back, and I will talk about, because the report just gives the figures. What we'll do is understand the plans that were submitted, the reason for the variation, and some of that could be down to some of the primary care offer and the locally enhanced services as well. So I'll bring something a bit more comprehensive back for the next meeting, Roy.
Thank you. Julie, and then I think we're going to move on.
Thank you, Chair. I had 2 points. One was to just seek some clarification around the 4.2% rise in referrals. Can I just clarify that that does or doesn't include referrals to mental health and all other referrals, or are you just referring to those that then trigger the weight limit?
So it'll be consultant-led services, so it'll be the waiting times for planned care. It will not include any community services.
My second point was just to add to what James was saying about the virtual wards and the 12-hour waits, is that we've also got large amounts of data that is showing that at least 7 in 10 attendances in A&E would be better managed elsewhere, and it's just maybe we also need to focus on how we work further upstream in primary care, for example, to reduce those numbers of people who are going to A&E where it's not the best resource, which then makes it very difficult for the staff to provide adequate care. Thank you.
That's probably a very good segue into... No, it's not quite the next item, is it? No, into an item further on around UEC, but I think that's... should we pick that? Can you pick that up then? Yeah, thank you. Okay, good discussion. A few areas for further work around there, but that was good. Next item is Finance and Contracting Committee Escalation Report. Steve.
Thank you, Chair. You'll be pleased to know I'm not going to go into the reports in detail. I'll take them as read, and to a certain extent they're somewhat historic, given that they relate to September and October, and indeed we had the November meeting last Friday, although even that feels a bit historic, bearing in mind we're in the following week. I think what I just wanted to pull out were a couple of points about the consistency between the reports and what they tell about the narrative of the journey the ICB is on. So the Chair's clearly identified that the ICB is committed through its plan to move from the deficit to a balanced position by the end of the financial year as part of the undertakings. And as part of that, Finance Contracting Committee has an oversight of the transactions as we need to reach that position, and indeed an element of challenge and scrutiny as we get there. What you can see through the reports are some consistencies in terms of those key variables that are the regular subject of discussion, which are fundamental to enabling the ICB to reach the balanced position we've spoken about. The report also picks up the development and evolution of the role of forecasting and reforecasting in the committee. It's not just about the here and now, it's about where we need to get to and how we get to it. So how do we manage those cost drivers? How do we deal with the risks? So there's an increasing degree of sophistication in that reforecasting, particularly looking at issues around risk and what the implication might be. The reality is, as you progress through the year with any set of financials, the element of risk either materialises or disappears through the effluxion of time, and that's just the reality of the progression. And the same is true of the mitigations, and you can see the mitigations in there. And partway through this process, September, October time, you could see that degree of sophistication and recognition of projected deficits of the order of about £104 million and a degree of sophistication of mitigations that could see us alleviate that. Nonetheless, none of that is a given. The next phase of, I think, the journey really reflects the development of the grip and control in terms of developing those mitigations. And we had a really good session this morning, not just looking at the financial challenges, but also the activities being undertaken by colleagues within the ICB, particularly in relation to grip and control. And that's really important because that plays to the credibility of the ICB going back to its conversations with the region and with the financial oversight provided by PwC and Stephen Hay. My summary effectively is that we are well on with establishing a path towards balance. We have the path towards balance. We have the mitigations identified. We have the grip and control which will enable us to get there. However, there is absolutely no guarantee that all of that will deliver the outcomes. So the focus very much, as you'll see through some of this, was about execution and delivery, and very much this morning was around outcomes. For the ICB, many of those positive outcomes in terms of that journey will be delivered probably months 8, 9 and 10, which feels, as the chair of the committee, a little bit scary because there's only 12 months in a year. So I've got 2 months left. But I think what is clear is that the ICB is doing all it can to deliver that issue that the chair has spoken about in terms of the undertaking towards a balanced position by the end of the year. I think there's a strong narrative and story to tell in terms of where we've come from and where we're going to. But as ever, the proof of the pudding will be in the delivery of those outcomes over the next few months. So that's probably as much as I'd say, Chair.
Thank you very much. Thank you. Any questions for Steve? No. So we then have the finance report, which is Mark. And we've had this conversation, Mark. So the finance, the report in for various reasons of ledgers closing and things, it's very, very tight to get the right timing. So this is actually month 6 report, whereas Steve was talking to month 7. We are going to try and sort that next month so that we can have a more substantive conversation about the most recent data. But that said, I think, as Steve has said, the messages are quite similar, aren't they, Mark?
Yeah. Thank you, Chair. I'll very briefly just touch on the month 6 position, just for I suppose, the notes of the meeting. But yeah, to absolutely take that point. Apologies to everyone that, again, we haven't got the month 7 position. That was reported to the Finance Committee on Friday. And as you've mentioned, we do and did talk a little bit about that this morning. We have been a little bit hampered by the new national ledger. We are working through that slowly but surely, but that does challenge us on a number of fronts to meet some of the deadlines, and we expect that will continue for a little while longer. But again, to your point, we will make sure that the timelines are as closely aligned as we can. So yeah, just very quickly, just to touch on the month 6 reporting position. Again, colleagues will recall we have a overall deficit plan for this year of £164 million that's supported by deficit support funding should we meet that value, and within that context we have to deliver in the region around £394 million worth of savings across the system. The system is judged as a combination of both the provider and indeed the ICB position. So again, within the pack you have relevant information regarding both the provider and indeed the ICB position. As a system, we were 27.8 million behind plan with a 61.5 million deficit against a year-to-date planned deficit of 33.7. You can see there that within that the ICB was reporting a break-even position against its plan, but with the remaining sort of variance on the provider side of around 27.8 million. As at the end of September, so that month 6 period, there was largely down to shortfalls on efficiency savings, both on the provider side, which makes up some of that provider side variance, but indeed on the ICB side, which was offset by other available mitigations. And then just to try and, I suppose, wrap up and align with Steve's commentary, on that basis, there remains a significant amount of risk in the H2 position, which, again, we're doing that work on the risk-adjusted forecast position to assess those risks and obviously look to the mitigations that we have within our control in order to make that get delivered in the way that we need to as a system. I will emphasise the mitigations, around those 4 or 5 key areas that Steve alluded to. In particular, some key actions around activity management plans, speaking to Asim's point earlier around performance and RTT and waiting list, making sure that we've got the right levels of activity, particularly with our independent sector contracts, but equally with some of our NHS providers as well locally. Some real work on other areas of ICB influenceable spend, so again in the areas of continuing healthcare, prescribing costs, making sure again we're maximising the resource that we have and managing any overspends and or pressures that we have in year. So again, lots of work going on by the teams on that, and we shouldn't underestimate the challenges there given previous issues that we've had. And then some work with other partners on managing other pressures. So again, colleagues will know particular challenges for our population in respect of some mental health pressures around things like ADHD, weight management, which again I know we've touched on a couple of times in previous meetings. Again, how do we manage some of those new and emerging pressures within the year as part of delivery of the overall position. The last thing I did want to say, which again was a feature of the Finance and Contracting Committee, which again remains very robust and very challenging in the right way, which is a good thing for the organisation, is that we continue to look at the reporting pack and the reporting process. That again has been a feature of some of the IAG conversations. I make no apologies for it being complicated, because it is complicated, NHS finance in general terms, but we are seeking to make those improvements in our reporting processes. So both from an executive perspective, but equally from a non-executive perspective, you're getting the relevant and right level of information to work that through. So again, hopefully in recent weeks and months, we've made some of that progress, but we continue to seek your feedback on, again, things that we can do better, and again, working with national colleagues within the constraints of the national ledger, which again doesn't give us absolute flexibility, but continue to try and do that. And how can we enhance our reporting in things like run rate and other types of analysis to help improve our oversight of the arrangements. So I'll pause there, Chair. Apologies again for the month 7 position not being with you today in the public format, but again we'll look to remedy that going forwards. Thank you.
Thank you very much indeed. Any questions? Yes, Aaron.
Yeah, thank you, Chair. So, really pleased in my first few weeks to see how serious colleagues are taking this agenda. It is partly the reason that we're in recovery support, and the undertakings are clear to manage our budgets. The risk at month 6, month 7 is higher than I'd like, but I can see the funneling, I'll call it, between the risks and the mitigations is getting narrower each month, so you can see some increasing confidence as to the profile that we're looking at. A couple of additional bits of reassurance for board. We are running a series of workshops in the next week or 2 with our incident management team, designed to get a bit crisper on the what, by, when and the trajectory of these mitigations hitting. And we haven't lost sight of keeping the pipeline being fed of other opportunities and other deliverables that we might seek to deliver over this period. The second point I would make is, Mark's just alluded to it, we are responsible for more than finance in the system, and outcomes, access to service and quality of service still feature really prominently in the assurance committees and in the executive committee oversight. So we're looking to strengthen the quality impact assessment processes through this next period. Also speaking to Silas as the PCB lead today, we have pressures on waiting lists, waiting size and RTT. You've heard Asim reference some of that. We need to make sure that we're still able to deliver also what was expected from our communities over this next period. And I appreciate the balancing act that is, but we need to be cognizant that it's a both and, not an either or. And I'll be challenging the teams and myself to work with system partners on how do we get the best delivery approach in this next 4 months, Chair.
Thank you, Aaron. Tracy.
Thank you. Just a couple of things from me on a kind of a system-wide, on a provider level. I just wanted to kind of understand a little bit more about the waste reduction programme and whether some of those schemes that we've implemented haven't yet been realised in terms of that cost reduction. I'm thinking particularly around headcount reduction across our acute providers. I suppose the assurance that Aaron's just provided is great, but I think what I'm sort of looking at is, were we expecting some of these schemes to deliver sooner, and not having the month 7 position means I can't really see how that's going to play out. So I'm just wondering around some of that. And then from a kind of ICB perspective, the voluntary redundancy programme, are we going to see any in-year savings from that? I'm suspecting probably not, but it'd be good to just have a bit of a clearer understanding of that.
Thank you. 2 good questions. Mark.
Thank you for the questions. I will do them in reverse order, if okay, because my brain's a bit fuzzy today, given how long we've been sat here. On the VR front, no, we don't expect any in-year savings. We've been given a provisional allocation that we think will more than enough be needed sorry, I'm trying to look at you, but speaking to the mic at the same time if I'm looking a bit funny. So yeah, that's a process. Obviously, we need to manage. We're early days in that sort of perspective, but we don't expect that to be the case. Your point on WRP is really well made, and again, I'll try and break down the answer. So we are heavily focused on the provider side conversations, including the IAGs on workforce reductions, relationship to the trust side, WRP plans, and in particular, what does that trajectory need to look like in order to deliver those plans? So that is very much being managed through the IAG conversations. Again, a couple of colleagues around today's table are front and centre in some of those conversations with other colleagues. I think we have a better WRP plan perhaps than in other areas where that profile is reflective of being spread across the year rather than being backloaded, if I can use that expression. So that is a particular feature which I think the system should take credit from, but notwithstanding, that does give a level of challenge to delivery of that. From an ICB perspective, again, the plan has been profiled across the course of the year, so I think we can reasonably say we are behind where we would want to be at this point, and you'll see that in the month 6 and no doubt the month 7 position. But I think it does reflect then an accuracy and an honesty of that position in a way perhaps that, again, previously if it's been profiled in the month 12 sort of profile, you kind of don't know that until the last few months unless you're really, really looking at the data. So I think it's the right light to be shining on our reporting position. We can and want to do more. I think the other factor, which wasn't directly in your question, but I think is a component of WRP, is the relative balance between recurrent and non-recurrent savings within that as well. Because as you will know, any non-recurrent delivery causes further problems into the new financial year. And again, we're very cognizant of that in the building up of our 26/7 planning assumptions, which again is happening right now in terms of where we are with that. Again, we're not where we would want to be with that. A proportion of our savings in year haven't been delivered recurrently, and we're having to find non-recurrent mitigations in year, or indeed trying to Aaron's point about stretching that pipeline to bring things forwards in a constructive way. So lots going on. I think, again, we're not quite where we want to be. We are a bit behind, but we're very aware of it through the reporting processes, and hopefully we'll make those strides in the remaining months. Thank you.
Thank you. Silas.
Yeah, just come back to provider cost reduction programs. If we take the headcount reduction, the areas that we've really concentrated on collectively have been sort of twofold. So one part has been about reducing variable pay down. So in particular, reducing the reliance on private agencies, reducing the reliance on waiting list initiatives and private companies doing that, the insourcing, outsourcing. I think we've made good strides with that. Again, bring that to life to you. So for Lancs Teaching, we now have 8 people on agency contracts across the entire organisation. So, you know, it's virtually been eliminated. Other areas that we've been looking at has been about sort of capacity, in terms of bed capacity. I think it's more of a mixed picture there. So I think some early success was achieved at the beginning of the year where we were able to transfer services into community settings, different care pathways. There was another round of capacity that was sort of due to be sort of going live in this current quarter. But I think given some of the pressures that we're still experiencing in urgent and emergency care, in particular around the long waiters in A&E, the crowding, the 12-hour waits that were referred to, a number of providers have taken the decision to pause those capacity schemes on the view that they wouldn't be safe to do at this stage of the year, and that further work's required. That's not to say that those schemes are being lost, but the timing's not right for those schemes. And then another large scheme that we're working on collectively is about how do we optimise our estates and managing those effectively through our 1LSC vehicle. Again, as we've got into that work, we found out actually the technical detail of that is quite involved. So again, working with ICB colleagues and working with PwC colleagues, again, we've not lost that scheme, but that scheme won't be sort of coming into effect towards the end part of the financial year, or month 12 in particular.
Thank you. Very helpful. Okay. I think we will go to urgent and emergency care.
Thank you, Chair. So you have a very detailed paper that I'm not going to go through page by page, but I am going to pull out some of the key and pertinent points. So this does cover our winter planning, but it also covers the requirements that we need to report to board as a part of the national UEC strategy that was published in June earlier this year. We've also took the opportunity to link our UEC improvement plans, the capacity funding, the regional transformation fund and key risks to bring it all under one paper. With regards to winter planning for 25-26, there was a number of board assurance statements provided by our acute providers to NHS England with regards to their readiness for winter. There are a couple of plans in the northwest there were several plans in the northwest with a couple that related to Lang South Cumbria where further information was required by NHS England to ensure that those plans were sufficiently robust. So that's about strengthening our winter preparedness, seeking particular actions to understand how we're going to address some issues like the long waiters in A&E, like some of our clinically ready for discharge to support flow. Each of those providers has now been supported with the developments and in relation to a resubmission, and I've put some additional resource in from the ICB to support those board assurance development plans. In relation to quality of care and patient experience, this was something that was raised at the last board and I said I would pick up in a future paper. So there's been really great alignment between our quality teams, UEC teams and our system coordination centre. Quality visits have been conducted around UEC and A&E, and key recommendations from those visits include improving communication with patients about waiting times, enhancing privacy and dignity in our waiting areas and addressing staffing levels to support quality of care. So they were key themes across the findings from those visits. The strengths were about the professionalism and compassionate staff, and I think that went across all of our providers, but some of the challenges do relate to, I think Silas just mentioned, long waits, some of overcrowding and some of the environmental concerns that we've been looking to address. So what are we doing about them, I think is an important issue for our board. Well, we've now got real-time queue updates, we've expanded urgent care in some of our pressured areas, we've enhanced staff training, there are patient liaison roles in parts of the system now where needed, offering better access to amenities and targeted support for vulnerable and mental health patients. And I'm sure later Chris might want to comment on some of the work we're doing with UEC with mental health, which I think is really exciting. We've got further visits as well planned throughout winter, so just to give the board some reassurance that this will be an ongoing process. Just with regards to performance, we're slightly under on performance. That's not unusual for us at this time of year. So we're slightly below the 78% target at just over 76.1% at the minute. Ambulance response, we are within our 30 minutes at 25 minutes 30 seconds, which is positive, and our ambulance handover 91.5% are done in 45 minutes, which again is positive. We'd like 100% because, you know, the other remaining percent is still people that are waiting longer than 45 minutes. The big challenges are 12 hours, and that does lend itself to what Julie was saying. We've got people in the department that could probably be dealt with elsewhere. We are increasing our call before convey with NWAS to try and make sure that we're getting the right support so people are not being conveyed. We have certain challenges at the minute. Blackpool, for example, where we have a higher number of professional referrals in, so professionals are referring individuals into A&E that then are not ending up being admitted, and therefore there is a view whether or not we needed to have conveyed those individuals, and they're not necessarily even an MWAS convey, they're taking themselves to A&E. So we've got some targeted work to do. That's all wrapped up in our UEC improvement plan for that particular area, because that's where the professionals and stakeholders come together rather than just having a blanket approach. So there's some really bespoke, tailored work to be done in each of the areas. We've got two of our providers, BTH and LTH, in tiering. BTH is tier 1 for UEC and LTH is tier 2, and that's where they're receiving support from NHS England, working alongside the ICB. We've had a busy time over October and November within our System Coordination Centre, with some of our providers unusually operating at Opal 4, which is not something we see a significant number of Opal 4 days, and we have done so. I think that just shows some of the pinch points and the pressures. We've had an infection trend rise in norovirus outbreaks and flu activity from early November, which is putting some pressures on the hospital as well. I've brought the UEC improvement plans here before, but what some of the areas that we're focusing on is particularly about the transformation opportunities, so looking at those alternatives and deflections and management outside of the hospital walls. So again, that's something that the teams are working on closely within each of those UEC delivery boards. We're utilising the UEC capacity investment funding. Tracy mentioned this earlier. We did, I think, in some ways, it was a brave step to put some of the money. I think we want to look at any further investment being increased for the voluntary and community and faith sector for next year. But some of the really great highlights for the schemes for this year have been Morecambe Bay Respiratory Network, Hospice at Home for Central Lancashire, End-of-Life Admission Avoidance in East Lancashire, and the work that we've done with our VCFSE in Blackburn and Darwin, Blackpool and Morecambe. They're the particular areas of our investment fund that are showing real great signs. So we want to be able to take that learning and roll it out and do it at scale for next year. Unfortunately, we didn't receive any Regional Transformation Fund bids for UEC, so that's been targeted at planned care. However, we still want to focus on the work that's within our gift, because it's not just about Regional Transformation Fund, it's about the whole fund that we spend on UEC. So we want to make sure we're getting best utilisation. And then finally, just risks. We've still got a risk with regards to testing some of our de-escalation plans. We are now getting in to throes of winter. We've got risks in relation to some of the patient safety and quality concerns, especially in relation to the 12 hours. We've obviously, I said, had an increase in some of our infections, and that's a risk, and we've seen an increase in COVID, and the junior doctors strike. Obviously, we've just had another strike. I think that was managed, I was on holiday, but it's managed relatively well, but it does present a further risk going into December. So apologies, it's slightly longer than usual, but there's been a lot now that we're required to report on, and I think it gives the board, hopefully, the assurance on all of the elements of UEC that we are working on collectively as a system. Happy to take any questions, Chair.
Thank you, Craig. Kath, and then I'm going to bring Julian.
Thanks, Chair. So thanks, Craig. Really great paper as always. I'm doing this kind of not with my DAS hat on. I'm doing this with my UECDB chair hat on. So just in terms of the achievements that are being achieved, happening, that's fantastic. But I did also want to just sort of mention, particularly for the South Cumbria patch, the work around intermediate care that's happened with a rapid increase. The challenge we've got, and it will impact on our ability in terms of being able to support those discharges, is around the funding arrangements for the therapy resources. Now, we have got short-term funding. It's proving very difficult for us to recruit. So I suppose if there's a plea, if possible this year, but going into next year, can we look at long-term arrangements for that therapy capacity, and then we can really do really good work around that and the intermediate care. Thank you.
Julie.
I really do think that we could do a lot more in primary care here, definitely with the movement of resources. It's also slightly worrying about the point 11.4 around the flu campaign. It's just to highlight that many of our schools have not yet commenced their vaccination programme, and we're seeing very high levels of flu, so I think things are going to be very, very difficult. But I do think that accessing the virtual wards, using our frailty hubs, our admission avoidance schemes that we've got in place, if we work together across the system and not identifying ourselves separately, I think we can make a big difference.
Thank you. Chris.
Just briefly, Chair, it was just on what Craig mentioned there around mental health for urgent care. So in the 10-year plan, it talks about mental health emergency departments. We have launched today a mental health review centre. So I think it's really important that there's still parity of esteem, and that for some patients, for some mental health patients, ED is the most appropriate place. But for those that don't need physical health intervention, a more therapeutic environment is much better. And so we've launched today the Mental Health Review Centre on the Blackburn site. The next rollout will be on the Blackpool site, and there are plans, but it needs capital works on the Preston site, and further conversations with Royal Lancaster and Barrow, but some good progress in that space to get into a position for winter.
That's good. Okay, yeah, Tracy. And then I am going to pause because we're going to have a 5-minute break.
Well, I won't delay us very much then. So just one final point, just thinking about some of the things that Julie raised, what Chris said about mental health referrals. It'd be really useful to understand the kind of care coordination picture across the patch as well, because we've got some pockets of really great practice. We've got some embryonic work that I think it's quite obvious where some of that can improve, and some of that is about engagement with primary care. So I don't know whether we could just have an understanding a bit more in terms of how care coordination is working and where the potential of some of that is as well, Craig.
I think that would be good. Can that come back to next board's update? Part of
I'll put
a
it
focus
in
on
the next,
that. Yeah,
as
exactly.
I addressed it in the last one, yeah.
Yeah. No, thank you. So I've got Jim and I've got Andy, and I am now getting slightly anxious about time. So just so that you know.
I'll be quick. As a collective system, we've done very well over the 3 years that the ICB's been in existence. So, I think we can take some assurance from that. So the system collectively works very well together. But every now and then we get an exceptional winter. And I'm just wondering to what extent we've got any contingency in play, or thoughts, or whatever, should we have an absolutely horrendous winter, which we have had in the past. Things have happened in the past where we've had to open extra wards, do a whole range of things to cope with the pressures. As I say, our system tends to cope, pretty well. But if things get really bad, where do we go, basically?
Yeah, do you want to?
Yeah, it's not an easy answer, that, Jim. But having just come from provider sector for kind of 20 years, I think what we've got is some reassurance as to how we respond under pressure if there are escalations. So whether that's the SCC infrastructure, what we've got across the provider collaborative mutual aid, the OPAL escalations, each provider will generally have areas that it can utilise, protocols for things like expanding in areas we wouldn't want to, corridor care, etc., or what we might do with any further resources for extra capacity. But I will say, with a system that's this hot and with limited headroom, we don't have a lot of areas to go into, so we're reliant on what we've done previously with a small amount of mitigation. So it's not an assurance response, but there's some reassurance as to how we've managed before with difficult winters. My one area that I would ask partners to kind of look at with a bit of pace is this vaccination issue. So if you can see in some providers they're up around the 60-65%, others are in the low 20s. So anything we can do collectively of system partners to encourage that vaccination programme in particular in the next couple of weeks will help pull through. We've also got some of the areas of work that we're taking forward with NWAS and with colleagues in general practice primary care that sit at the UEDCB chair level that Kath manages at Place. So I think we should have confidence in our Place leadership teams in this area that will manage the winter through.
Thanks, Aaron. Andy, and then Silas. And
Thanks.
then
Just a couple of points then, Chair, and I will try and talk quickly. The first thing is to say that I agree with Julie, and I want to say primary care is under more pressure and doing more appointments than it ever has done in its history. So, we're talking about millions of extra appointments across the system. And so the answer can't be more work done in primary care. It must be about system joined up work with community voluntary faith sector and with and. So so I'm not saying no, it can't be a preventative approach and working more proactively. I'm just saying we need to work wisely and not just say the answer is just shifting work somewhere without also understanding some of the pressures there. Otherwise we're going to find some entrenchment and some difficult behaviours, I think, because people will feel done to rather than included in the solution. The second thing is on vaccinations. I picked up a conversation last winter with NHS England about some of the complexities around the vaccination programme, and I am concerned because this year GPs are already saying to us they've had to order the vaccines for next winter, and they're already saying they're not going to do it because they are making such a financial loss now on the vaccine. They have to predict how many vaccines they have to order. They are then wasting hundreds and hundreds of vaccines because they're running clinics, but people are saying, well, they've already had it at the pharmacy, or there's a reticence from the people to come forward. And there are literally dozens of practices who've already been in contact to say, next winter, we're not providing this. So you're going to have to find an alternative solution, which means a proactive conversation. I'm just giving the board forewarning. As medical director, I will be taking that conversation forward with the Director of Public Health, but particularly with NHS England. We've got to have a scheme that works effectively for our population, but also in partnership with those who deliver the vaccines, because currently the methodology has stopped working very effectively, both in terms of cost remuneration for the amount of work done, but also for the complexity of then trying to engage with a population who've become more reticent to be vaccinated, including our own staff. So it's not an easy thing to increase vaccination rates. There are schemes that do work, and working really proactively with the community voluntary faith sector particularly, and putting our vaccine reach out into different places is going to be part of our strategy. But Jane and I will be working together with NHS England and our Director of Public Health and primary care colleagues to think about how we really up our game in this area. But it is not, unfortunately, a particularly straightforward playing field at the moment because of the way that things are currently being commissioned.
Okay, thank you. Silas.
Yeah, just coming back to Jim's point, I think the point there is about exceptional winters as opposed to sort of a normal busy winter. I think based on the many years of experience we have had of dealing with winter pressures, and unfortunately the pressures that COVID bring, we're good at this now. Recent example was some issues that we had at Longreach Hospital with Chris's organisation, where we had to rehouse a number of patients very quickly. We did that safely in the space of less than a week. So we know we can do it if needed. All of the provider organisations have actually revised their trigger points when we escalate now as well. We've done that collectively. I think there is a nervousness, though, if I'm being perfectly honest, this winter, just based on some of the experience in the other side of the world in Australia, where they've had a very difficult flu season this year, and that tends to predict that we're going to have a difficult flu season in our half of the world as well. So we are watching this very, very closely at the moment. I think that the real issue will be, yes, we can mobilise, yes, we can find space. We don't have a budget for it, though, so there will be a financial consequence if we have to do that.
Thank you. Thank you all very much. So I propose that we take a 5-minute break back at 10 past for the last part of the board. Thank you. Who are we missing? We're missing Jane. We're missing the clinicians.
Yeah.
Nope, no, yeah. Are you happy to start? Because I think otherwise we're going to... Okay, welcome back. We are now on our next section, which is developing the system and strategy, starting with the medium-term planning and strategic commissioning framework, which Aaron is going to lead.
Thank you, Chair. So a slightly unusual paper. I don't generally like to bring papers to board for note, but this is partly for the board's reassurance around our approach to producing quite a few products over the next 4 months. And given the complexity of the ask on us, I thought it would be helpful to have a repository of a single view of all of the programmes of work and how the board will get its opportunity to check, challenge and assure before these products are signed off to go into the central kind of repository. So we have had 3 or 4 very important documents over the last 3 months. So we've had the medium-term planning guidance, then we've had our strategic commissioning framework, we've had our financial allocations, and then we've had detailed planning guidance. And our teams have been working really hard through the late summer and early autumn, I can take no credit for this, with system partners to start to construct responses to these documents. The paper articulates what the asks of the ICB are in each of those areas of responsibility. Some quite traditional in that medium-term plan currently, finance, operational activity and demand, workforce. But there are some further elements of development for us to consider in that strategic commissioning framework around joint strategic needs assessments, what it means to be a market manager, what the payer function might mean. So the intention over the coming weeks with partners and with the EXCO is to build products in response to these programmes that will feature for the first time with the board on the 11th of December, and we'll check in as to the current status. In the main there, Chair, it will be around the finance, workforce, demand and capacity, so quite traditional. We're going to run, bless you Jim, we're going to run a workshop on the 18th of December, which will have a further iteration of the medium-term plan, but we'll also talk a bit more broadly around the strategic commissioning framework. That will inform the submissions that are due on that Friday on the 19th. Through January and March then we will run a further series of workshops with the board to finalise before March the submissions that are a little more strategic. So that's there for board reassurance on the roadmap, the products that we're developing, where the assurance committee role will play and where the board will get its opportunity to check, challenge and contribute. I just wanted to finish, Chair, by just recognising a couple of things. We talked about a voluntary redundancy scheme and further restructuring of the organisation that will happen from now until the end of March, the same period. That creates a risk in terms of capacity and capability as we work through this programme. We are keeping our senior leadership team and the executive committee close and will work with the board as development, but I can't let this go without recognising that as a risk. We did have a risk at the start of producing this paper around uncertainty around the financial allocations, which we've now had, and we can feature in the first iteration when we come to the board in a couple of weeks. We also need to recognise, I think, a little bit of expectation setting. You and I have had this conversation early, Chair. Our ambition, you can see and hear, round this table with ICB board and partner members to move quickly into that strategic commissioning framework space. I'd use a phrase of chomping at the bit, using data differently, having different constructs of our contracts, looking at longer term measures. That is where we all have an ambition to get to. We're not going to do it in 6 weeks. So some of the products that we design will recognise that there is a further development path through 26, 27 to develop properly. So have that in mind as we sort of take forward what we need to. We will absolutely need to satisfy the national guidance and the objectives of delivery for next year, but I suspect the system development, the strategic commissioning framework development and partnership development is going to feature as part of our objectives through 26, 27. So just a couple of minutes, Chair, just to bring the paper to life, and I'm happy to take any questions or comments.
Thank you. Thank you very much, Aaron. Sakthi.
Thanks, Aaron. That's really helpful to just lay it out like you've just done and the timelines. By default, this is going to require, whilst you've got to meet the timeline set by the NHSE nationally, as you've just mentioned, strategic commissioning by by design is strategic and involves partners. Improving neighbourhoods and neighbourhood health plans is beyond the NHS, although NHS is right at the centre of it. I just wonder whether, I'm sure you're already considering this, that this needs to be socialised in the planning worlds of partners, just so that the expectations, as you set out there, are managed. And certainly places like the Health and Wellbeing Boards are mentioned here. It's a real opportunity to, whilst appreciating the risks and people moving on and so on and so forth, there's a real opportunity as well to really come together and hold this as a system.
It's a quick response, actually. Yes, there is the intention to do that with partners, but again, setting expectation, we're talking about weeks here to finalise products, so it will be at the contact reflection and how do we want to work in the future together. I would suspect that 26-27 process will start pretty early in 26-27, particularly on the system development pieces.
I think I'll just add that for me, one of the most important parts of this document is the gap paper, which is the setting the foundations, the Appendix B, which talks about our assessment of where we are, because for me, a really important part of doing this work is understanding where we want to do it better next time round. And I think so long as we've got that, that will start to address your question, I think, Saxi. Yeah, that's a part of our submission, but for me, it's also a really important part of our own thinking and development.
I think Sheena wanted to go.
Yeah, okay, Sheena, and I'll come back.
Really helpful paper, thank you very much, and also helpful, Aaron, in terms of that context setting and your point, Emma, about the gap bit. I think what I'm particularly keen is that we are really clear about the milestones that we expect to achieve and where, and not only on that, but the outcomes and impact we'll have done, because I think it'd be very easy in this to drift, and actually we don't have time to drift. And I absolutely get the bit about getting the right balance between the fact we haven't got capability and capacity challenges, but it's actually making sure that we're clear about what are the milestones, what do we want to hit, and where do we want to have got to in a realistic way, but still with ambition. So I think it's just to make sure we're clear as that as we go forward. Thank you.
Thank you, that's very helpful, Sheena. Saxi.
Just to offer, there is more work that we need to do together with partners. I mean, don't want to speak for all partners, but definitely for County Council, I'm sure Kath would agree. And another contextual piece that's really happening at the moment is local government reforms. And these timelines and those timelines, if you don't cite them in our work and milestones, we might miss. Again, it's an opportunity and a risk as well. Thank you.
Yeah, absolutely. Kath?
Yeah, just to endorse everything that Saxley said, yeah, and I think I can speak on behalf of the other DASs in relation to that as well, that it's really important we're all aligned and working together on this. And neighbourhood, there's some things that local authorities have done very well for a long time around neighbourhoods, and it would be great to share that learning and really do it as a journey together.
Excellent, okay. That's great. So we will follow that timeline, and we will bring to the board as in line with this paper. So thank you very much indeed. Okay, the next item is the voluntary Community Faith and Social Enterprise Alliance partnership agreement, which Tracy and I signed before the board meeting and have been photographed shaking hands over. Craig.
Thank you, Chair. I'm just going to do a couple of opening remarks and then pass to Tracy, so a bit of a double act. So this partnership agreement between the ICB and the VCFSE Alliance originally was born in May 23 and sets out the principles of how we want to jointly work together. And that's about maximising the opportunities. We've heard about this through UEC, we've heard about it through neighbourhood work today. I think it's been brought alive in a number of the papers. And it's all about improving that health and wellbeing across Lancs and South Cumbria. And I think this is a great opportunity. And that affirmation and commitment, I think, is really important. We want it to be, and I think it is, and Tracy's alluded to some of this today, a strong and effective collaboration, but I think there's more for us to do, and we can go further faster. So this has been a joint paper written between Tracy's and colleagues and some of my team, and I think it really does show how the contributions of the sector can be unlocked to give us greater opportunities by creating the right conditions for how we need to operate in what is a very challenging environment for all of us across the patch. So I'm not going to go through the paper, but I do think it shows how we're shifting in that strategic commissioning space and where we've got the voluntary community and faith sector as key strategic partners, not just about enabling us, but about being a part of that provision offer as well. And I think the input into our commissioning intentions work has been phenomenal, so grateful to all of the stakeholders that have been involved. And in fact, I think nearly every workshop we've had representatives from the sector, which has been really encouraging. And we want to continue that work and have that burning platform to go forward with the partnership agreement. So Tracy, I don't know if you want to add anything else.
Thank you. Thanks, Craig. I just want to add some things about kind of where we started with some of this around that coming together, because this agreement is sort of the architecture really, but the things that have really shifted the dial on the way in which we work together, and there's been some as Craig said, some real leaps forward, real progress around some of this work. Still a lot to do, but I will talk a little bit more about that. But what the agreement did really was act as a bit of a catalyst, and it also provided some investment into the VCFSE Alliance to free up my time, to allow me to come here. And I think some of the things that I've been able to contribute around this board table have also made a difference around some of the thinking and decision making. It also enabled Craig and his team, particularly Jane Cass and Claire Roberts, to form those relationships with people like myself in the sector, Angela Allen, who's the Deputy Chair of the ICP, Jo Hannah, who's programme managed a lot of this work. And if it wasn't for those relationships, a lot of this wouldn't have happened. So I just wanted to frame that really, because sometimes we think about the policies, the structures, the agreements that we put in place. And actually, the bedrock of this work has been those relationships. And that wouldn't have happened without us coming together and saying, let's invest in the VCFSE Alliance and let's look at all of the opportunities that we can see at the moment where we can invest in some of those services that we can deliver where we know the difference will be made. So you can see in the report, there's 3 case studies that give you a really good indication of how we are, and I talk a lot about this, pointing the VCFSE in the right direction. And that's what I mean when we talk about integrated models. I talk about services that exist, that they might need some investment to be able to deliver a little bit more, to deliver in another community where they maybe weren't delivering before, like some of the UEC work. But it isn't just about doing that in isolation, and it isn't about saying, let's move some money to put into an organisation in the VCFSE sector. It's about, let's look at collectively where that investment is going to make the biggest difference. And that's where I think we've really started to change our thinking. But, as Craig said, and I'll say, there is so much more we can do around this. And there's a few asks from the VCFSE Alliance that we've just wanted to bring today. One of the key ones is where we are around the table. So, Aaron, you talked right at the top of this meeting about having a meeting of the execs of the board where you talked about lived experience. I think we're absent in those spaces where we could make a difference. I notice on the last paper, there are some key dates around the 11th and 19th of December where discussions are taking place, where sector colleagues could make a huge difference. And I don't mean to sound like I'm being in any way critical, but when it's NHS talking to NHS, you get NHS solutions to problems where you need system-wide solutions. So I suppose it's a plea really from us as a sector where we've been able to be in those spaces around the UEC work in particular. We've seen the change and we've been able to influence that change. And to the credit of colleagues around this table, people have embraced that and really listened. But I think we need to do more of that. And one of the others is, in terms of that ask is, keep investing in the VCFSE Alliance, please, because that is absolutely the crucial piece of work that has made much of this happen. And I know it's really difficult around the current climate, but there are key people across the ICB who we've worked with who have really made a difference to the way in which we approach programmes of work around VCFSE. I've seen over the years I've been involved in this work, in work in the charity sector, we sometimes lose the memory of what we've done because we lose the people. And I think that is so important for us not to forget. There's a lot of very skilled, very knowledgeable people working across this system. Can we please be mindful of that as we move forward with a lot of the work that we're doing? Thank you.
Thank you. Thank you very much, Tracy. And I hear you about the presence, and I am giving it some thought. So watch this space. James.
They're teasing me with the James today, but yeah, I just want to be very supportive and encouraging of what we're talking about here. I think we do absolutely need to support the strengthening of the partnership. If anything, it's the area where we get the biggest return on investment. We get a phenomenal return for what we invest in this area. So, well done to all concerned, particularly to Tracy, but also to the rest of the team, to Craig and all his team, and people from other sectors and so on. It's a really important piece of work, and it is a success story, I think, for the ICB. So, more of the same, really.
Thank you. Did I see someone else's hand? Yes, Jane.
Really, really welcome this, and echo your comments. Actually, Joe and Angela have been on People and Culture Committee and have made a fantastic contribution there. And I just want to raise awareness of the real potential that exists for us to work across the system with the VCFSE sector. That's hard to say when you've got braces on your teeth. Can I say it differently? Around things like workforce and education training, career pathways, particularly not just linked to the delivery of health and care services, but also that kind of wider agenda we've got around social and economic development and into communities, pulling people through and creating opportunity. Now, we've not yet done as much as I would like on that, and that's partly, I think, due to capacity issues, not just for the ICB, to be fair, but also in your sector. But I just wanted to mention it here because that opportunity does exist, and it's something that would be really good to try and progress over the next few years.
Thank you. Excellent. Do you want to come back, Tracy?
Absolutely agree on the workforce development side of things. I mean, I could have talked at length, as you can probably imagine, about this work. And one of the other areas that we're really conscious of as a sector at the VCFSE is making sure we've got system leadership programmes of work. And again, part of the investment has resulted in us doing a piece of work, and it actually started with some work, I think, we started with Debs, around looking at how we organise our sector in the best way so that actually we've got those system leaders in the right place. We're not there with that yet, but again, this has been a catalyst for some of that work, because we're conscious that we need to have the right people across our workforce within our sector, but also we need to be in those spaces where when there are opportunities, we're kind of commissioning ready, and we're wearing that right hat and that right attitude. And again, leaps forward in that, but still a lot of work to do around that. And I think some of the examples of where, and Jim said it, we do get a big return on investment with this work. We can see some tangible outcomes from this. And some of that was about, and it was mentioned before, about Spring North being able to operate in a very different way within our sector as that responsible kind of body to hold the sector to account, but also to say back to the NHS, some of the metrics that you're asking us to measure are not appropriate for our people and communities. And again, creating that structure around that accountable body has really allowed us to show that return on investment in a very concrete way. So, some of the schemes that have happened in Blackpool, we're showing 400 emission avoidances. And for a very small investment, again, go back to what Craig said before, the 2% has made that difference. Imagine where we could be if it was more investment. I think we have got the call to action around the 10-year plan to do some more of this work. And I understand it's really, really difficult. If I wear another hat, I'm a non-exec director at Blackpool Teaching Hospital. I understand internally the pressures that we're facing as a system around the financial environment, the demand for our services. But I also see that if we don't do some of this work, actually that is not going to improve. And when we came together originally and signed this agreement, I think we've taken some small steps towards that. I'd like to think if we're back again in another 3 years, and I'm looking at Aaron now because Aaron's also made a commitment to meet with the VCFSE Alliance on a fairly regular basis as well to help drive some of this. I'd like to think if we came back in another 3 years, re-signed that agreement, we've got even more examples. And in many ways, as a system, we're showing other ICBs how to do some of this work. So I'll stop there. Like I said, I could go on.
No, it's fantastic and really inspirational. And I think you've definitely, we are very, very supportive as a way forward, and we need to think about our ways of working and our mechanisms to make it really embed and grow. So thank you very much indeed. Okay, so we now move to the final section, which is governance, and with the Audit Committee Escalation and Assurance Report.
Thanks. I did actually report on the committee to the last meeting, and it's minuted, so I'm not going to add very much to it, other than to update a couple of the points that are made in this AAA report. The first thing is to say the new ICB financial system continues to be a problem. It's not a problem of our making, it's a problem imposed on the organisation, but Mark and his team are doing very well to produce what they're able to produce, but it's not everything that we would want to see, basically. So if you wanted a case study about how not to implement an IT system, this is it. But that's an ongoing issue. I'd also just quickly mention there's a reference to the CHC Adams system. There's also work ongoing on that to make sure it is producing the information the way which we need it. And finally, we've often mentioned the need to follow up on the internal audit recommendations, and through Aaron and Mark, a lot of work is going into reducing the number of outstanding ones, and I'm hoping at the next audit committee next month we'll see quite an improved, reduced number basically of outstanding issues.
I'm very pleased to hear that. Any questions for Aaron? No. Yep. Sorry. It is getting to the end. Sorry, for Jim or James. No? Okay, thank you. So we now move to the North West Specialised Joint Committee Escalation and Assurance Report. Craig.
Most of what's covered in the alerts and advice from the 5th of June are then updated in the following meeting. So just to bring from an alert point of view, the transfer now, which is different to the delegation of specialised commissioning services, so they'll be transferred, isn't planned for 2026 as originally alerted to the board. It will be the 1st of April 2027, and no additional or new delegations will happen in the meantime. There is now what they call an off-pick, which is an Office of Pan-ICB Commissioning in each region to be hosted by one of the ICBs, and there's work ongoing and a board been established between the ICBs and NHS England to confirm arrangements. Have we confirmed arrangements? Sorry, I've been off. So
apologies, Craig. No. So it's been reconfirmed that Lancashire and South Cumbria ICB would be the host of this arrangement. There's been a development board established that myself and Linda Charles-Zuzu, who's the Director of Commission Region, will chair. It'll feature in our transition committee, and then we'll find a way of dovetailing into board under Craig's update. So that's been a progression. It's moved quickly while you're on leave, Craig.
Thank you, Aaron. And then there's a number of decisions under advice that the Joint Committee took with regards to lead providers for mental health, collaboratives for eating disorders and CAMS, the work programme for neonatal services, and from one of the previous ones, the issue we had regarding adult critical care transport services. So they've now been further updated at committee. So happy to take any comments or questions on any of the alerts or the points for advising.
Thank you, Craig. Any questions for Craig? No? No? Yeah.
Just a reminder that we are scheduled to chair this committee from next year, I think. So we need to make sure we got someone to chair it.
Fine, I was right then. Yeah, fine. Okay, thank you. Thank you very much, Jim. Okay, we will move on to Freedom to Speak Up annual report. Asim.
Thanks, Chair, and I'll take the report as read, but I will bring out some of the pertinent points. This is a really important agenda, and this is central to promoting an open, safe culture where colleagues feel confident to raise concerns. And the report describes how the service has matured over the year and how we are aligning to the National Speak Up, Listen Up and Follow Up framework. So over the last year, we've updated our Freedom to Speak Up policy and the supporting operating framework around that, which clarifies the route for raising concerns and including the anonymous option. It's part of our staff induction now, and the communications have been strengthened, and we had the follow-up in action theme as part of the National Freedom to Speak Up week that we had recently. Compared to the previous year, we've seen fewer concerns, and this is not a performance metric because the fewer concerns does not necessarily mean good, but most common themes relate to behavioural and relationship issues, followed by system and process matters. The focus moving forward is around strengthening system-wide collaboration, ensuring service is sustainable, because we do have some capacity issues in this service, and how do we embed learning from the concern into our organisation development work. Quarterly updates go to the People and Culture Committee, with additional assurance going to the Audit Committee as well. I'll leave it there, but before I open up for questions, just want to like to thank the Freedom to Speak Up champions and our two Freedom to Speak Up guardians, Sarah Mattix and Rachel Holyhead, who undertake this really important work alongside their substantive responsibilities, and they do a fantastic job. So I just want to really thank them for their work they do. Happy to take any questions.
Thank you, Asim. I really feel this is a very, very important thing, so I'm very keen that we understand the report and what it is, and I'd like to bring Jane in, who is our Freedom to Speak Up champion on the non-executive lead. Non-executive lead.
Yes, the terminology. Hugely important area, and I want to commend Asim for his leadership and also thank Rachel and Sarah. We've made huge progress in this space over the last 12 months, really, in terms of communications and policy development and delivery of the service. And I want to make a plea that we must keep this service going, and we must look at these issues around capacity, because we are stretched and we have to address that. I think as we go forward through this transition, this will be a really useful kind of release valve to make sure that we are carrying out work in line with our values and to learn from areas where that isn't happening. So thanks to Asim and colleagues in this.
Thank you. Sorry, did you want no? Any questions? Yes, Tracy.
Thank you. Absolutely welcome this. Thank you, Asim. I think it is such a vital area and really reflect what Jane's just said. I'm just mindful of the feedback from the People Committee around a climate of bullying and some of the things that we talked about earlier, and the use of the Freedom to Speak Up service as in the right way, so it isn't used in a way to bypass that line manager responsibility. And I think, everybody is grappling with that. I think to have it be used in the right way, so actually change can happen, and it isn't really just somebody bringing a problem and not seeing, because that in itself, and as you said, an indication of a lower number of problems is not necessarily a good thing, but I suppose it's just being mindful of the fact that it's an addition to that very, very clear line management responsibility, and not a way of people moving that responsibility from themselves.
Thank you. Thank you, Tracy. Sheena.
Yeah, it was really to build on the point you're making. Build on the point you're making, Tracy, because I think, you're absolutely right. This is part of a suite of how people are able to make improvement, because, you know, as some quite rightly said, this is about how do we have an open and transparent culture, but also a learning culture. So people have the opportunity to both raise concerns, but raise things that could be even better, and how we place this within a suite of those things, notwithstanding that absolutely needs to be a channel whereby people feel that they're not being listened to, that they can raise those concerns and can have those issues addressed. I think the one thing that I just wanted to understand was about whether, and I think we have, tested people's confidence in using freedom to speak up, because I don't think it's in the report, is it? But I think it would just be useful to kind of sit alongside that and just to understand, particularly, do we have any pockets within our organisation where either there's low reporting, which might be because actually, do you know what, people feel that they can have their issues addressed locally and they don't need to raise concerns, or they don't feel confident, you know, sort of it's the yin and the yang of it, really. So it's just kind of getting a bit further underneath. But I think this is a core bit of part of our whole bit about people having that opportunity to be an open and transparent organisation that learns and improves. So thank you for the report, and thank you for, it's a tough job, the people, both your role, Jane's role, but also, most importantly, those people in the organisation that are making sure that this is widely understood and used effectively. Thank you.
Asim, just before I bring you in, can I add one more question, which is about the primary care aspect of it and how we are coping with that? Thank you.
Okay, I think because our numbers are relatively low, so we have 21 concerns compared to 30 concerns, it's difficult to do any thematic analysis, really. And as Tracy has mentioned, this is a suite of different channels, and what you may expect as we go through significant change, there might be an increase in freedom to speak up concerns, but there hasn't been. And there's no evidence behind it, but my assumption is there's been a real open dialogue and conversation with our staff, including anonymous channels, and I've seen real openness and willingness to share concerns openly. So I think that points towards some of the sort of low numbers, but it's small numbers. In terms of primary care, it's a really good point that you've raised this. We do hear concerns from primary care. Not all ICBs hear concerns from primary care, nor do we have to hear concerns from primary care, and that has to be part of our analysis when we look at our capacity constraints. And I've got the picture from our neighbouring ICBs in relation to what they do. But saying that, it does bring a lot of benefit to us, because we can then triangulate some of the quality aspects as well around that. So there is a paper I am drafting with the support from the Freedom to Speak Up Guardians around how we, as Jane said, how do we resource this adequately? And there'll be a question around whether we continue to listen to primary care concerns, or do we point them to another direction? So it's a really good question, Emma.
Fine. I think it's quite an important one. Debbie?
Yes, I just wanted to consider this in the context of some of the other information, because what we've done in the People Committee is triangulate the information from the Freedom to Speak Up with our staff survey and other data, you know, sickness, absence and things like that. But one of the things that we considered as part of our pulse survey feedback in July was the fact that staff were saying there's a confidence in raising concern. However, their concerns were that there were repercussions as a result of it. But one thing that we do know, because I know that the Guardians have undertaken surveys, staff feel comfortable speaking to them, and that's a positive. But as part of our culture work, which is the work we're still ongoing, that is still ongoing, is to support staff to feel confident to raise concerns across the board, be it with their manager, without repercussions, and that's the work we're doing.
That's very helpful. Okay, so I think generally very strong board support for this, but the appreciation as part of a suite of measures for staff. But thank you very much. Okay, the final report is concerning matters considered in the private board meetings. Deb, is there anything you wanted to say?
Thank you, Chair. Just really briefly, the board's met on 2 occasions in private since the last board in public. The focus of those meetings are included in the report, and again we can see that a number of those items have been brought through into the discussions today, including the weight loss drug, financial position, discussions around model ICB and how we start to transition. Thank you.
Thank you very much. Okay. Any questions? No, fantastic. So any other business? Does anybody have any? No. And then we've got items for the risk register. Have we picked up a few actions along the way? I don't think there's anything specifically for the risk register, is there? No. No. Okay. And then closing remarks, just I think we've had some quite good conversations, and I think we need to, increasingly we need to turn those conversations into what are we going to do about them, which I think we started to do a bit today, so that we're always very clear that it's not just a comfortable conversation, but that was good. Thank you. And thank you very much for those that have sat through, and I think we will now declare this meeting closed.